Hi, good morning, everyone. Thank you for joining us. We're going to begin our perioperative program, and our first speaker is going to be Dr. Mikaela Yemen, intensivist at Northwell Hospital, to talk about common complications after cardiac surgery.
Good morning, and it's a pleasure to be here with you today. My talk is going to be two parts. The first half will be two topics dealing with some of the common complications we encounter in cardiac surgery. Let me figure this out. There's a lot of issues we deal with in the perioperative period, but I thought these were the most common issues to kind of tackle and address. I'll try to go over some of the new ideas and novel treatment options we have for management of these complications. So we'll start out with arrhythmias. As you all know, arrhythmia is probably the most common complication. Since I'm far away and I'm less likely to be infectious, I'll take this out. I apologize if I cough during this talk. I'm recovering from a cold. So arrhythmias are very common in cardiac surgery. Out of these, atrial arrhythmias are probably the most common rhythm issues we deal with. Luckily, ventricular arrhythmias and bradyarrhythmias are less frequent. And for the most part, we don't really have to do too much about bradycardia and conduction disorder. So I'll briefly mention that towards the end of the talk. Out of the atrial arrhythmias, probably postoperative AFib is the most common issue we deal with in the immediate perioperative course. So what is postoperative AFib? The definition is new onset AFib that occurs within 24 to 48 hours after surgery. It commonly presents as paroxysmal AFib, but in some patients it could present as persistent AFib. The good news is for most patients it's self-limiting and resolves within 6 to 8 weeks. Postoperative AFib can happen in any type of surgery, but it tends to be more prevalent in cardiac and thoracic procedures. The overall incidence of post-op AFib is reportedly about 30% in all cardiac cases, but higher incidences are reported in valve surgeries and more complex aortic procedures. So what is the mechanism of postoperative AFib? It's really a combination of interplay between physiologic conditions and surgical conditions that predispose patients to post-op AFib. The big key player is that inflammation. So there's a stress to the body that's caused by the trauma of surgery, and we all get this fight or flight response, a catecholamine surge, and activation of our autonomic nervous system, and all that tends to lead to the development of postoperative AFib. In cardiac surgery, there's also local inflammation that happens because of manipulation of the heart. You have things like retained blood in the pericardial space, disruption of the epicardial fat, which is known to contain parasympathetic nerve ganglion, and then the use of cardiopulmonary bypass in itself causes systemic inflammatory response, but also some ischemic reperfusion injury to the pericardium. So all this contributes to the risk of post-op AFib. What other risk factors are there? So you can divide that into patient-specific risk and surgical-specific risk. The patient-specific risks are comorbidities that most of our cardiac patients have, like advanced age, structural changes to the heart, whether it's left atrial enlargement or systolic heart failure, and then a lot of medical conditions like COPD, hypertension, diabetes, presence of anemia, renal failure, all increase the risk of AFib. From the surgical risk standpoint, the type of surgery being performed, but also the complexity of the surgery also increases the risk of postoperative AFib. And if you look at the risk factors listed under intraoperative and postoperative risks, they really are more suggestive of severity of illness of the patient and complexity of surgery. This is as it relates to cardiac procedures. Basically, majority of our patients have some level of severity. So in a sense, most cardiac patients are at a higher risk. And the sicker the patient is, the more likely they will have postoperative AFib. And we see that every day in our more complex patients, the ones that bleed and need reoperation, they tend to be the ones that develop AFib. So I mentioned cardiopulmonary bypass use. So if we can avoid the use of cardiopulmonary bypass, can we reduce the risk of postoperative AFib? And that's a big question that's been asked by multiple studies. If you look at the large randomized control trials that compared on versus off pump procedures, the data was actually inconclusive, right? They basically said off pump didn't really have much benefit, there's no reason to do off-pump surgery. But recent small single-center studies, randomized control trials, have actually disproven that there is benefit in proceeding with off-pump CABG in terms of stroke rate, AFib rate, renal failure, as well as need for transfusion and ventilator days, and that data is being supported with the current evidence we have. So next question is there a way to predict postoperative AFib? Not all of our patients that undergo cardiac surgery develop it, even though they have similar risks that tend to predispose them. Many risk scoring systems have been evaluated. It's listed there. Out of all of these, I think the CHA2DS2 score has come out to be the winner, and I'll show you why. The CHA2DS2 score was initially developed to predict the risk of the risk of stroke in patients with a history of persistent AFib. It's an upgrade of the old CHA2DS2 score, so they're very similar in terms of what they calculate. This study is probably one of the earliest studies that showed the utility of the CHA2DS2 score, and it's a prospective study looking at about 277 patients who underwent cardiac surgery. The AFib rate in this group of patients was about 30%. I don't know if I went back, about 30%. So 84 out of the 277 patients developed AFib, which is consistent with what we see in literature. The authors used both scoring system, the old CHA2DS2 and CHA2DS2, and what they found was a score greater than 2 was more likely to predict the rate of AFib. But if you look at the cohort of people in the CHA2DS2 group, a score of 0 or 1 didn't really discriminate those patients very well. What they did was they took these small group of patients with a score of 0 and 1 and then recalculated them using the CHA2DS2 score. And what that showed was it really was more discriminative, and it tended to be superior in predicting the rates of AFib. The reason for that, or at least the proposed reason for that based on this study, was patients with a CHA2DS2 score of greater than 2 on echo and on basically history were more likely to have hypertension, diabetes, but echographic signs of structural heart changes. They had enlargement of their left atrium, structural changes of their ventricle, which predisposed them to arrhythmias. Other studies have actually proven this. And as you probably know, the CHA2DS2 score is probably the best accepted model for predicting AFib. What the cutoff is, I don't think is quite clear. Most studies use a cutoff above 2, but some studies have used 3 or above. So in general, I think a cutoff above 2 is accepted as a risk for predicting postoperative AFib. So what do we do with that? And we'll talk about how important that becomes in deciding prophylactic methods and certain management strategies. So previously I mentioned most patients go back to sinus rhythm within 6 to 8 weeks. So why do we care so much about postoperative AFib? The big issue is it increases morbidity and mortality. And I think that is a little bit not 100% true, because I think most of our sickest patients end up having AFib because they're sick rather than, and that's why they pass away, not necessarily because of the atrial fibrillation. But we do know that there's increased risk in their morbidity and mortality. It also increases the risk of stroke. So patients with post-op AFib are likely, they have a 2 to 5% increased risk of having a stroke. And they're also at risk of having persistent atrial fibrillation, which is, understandable since we said they probably have some underlying structural heart problems. But the big thing is cost and length of stay. We know that patients with post-op AFib are likely to stay in the ICU much longer, up to 2 to 3 days, and their overall hospital stay can also be increased by several days. This leads to cost. Average number you'll see being quoted is about $15,000, at least in the US. And I think to kind of bring that a little bit more, bring that clarity into focus, a study that was done in Virginia looking at a 10-year span, they used their STS data and they looked at certain complications and how much it costs to manage certain complications. And the cost to manage postoperative AFib in the state of Virginia, based on their STS data, over a span of 10 years, was actually $27 billion. It's a lot of healthcare dollars that we're spending on the management of this condition. And if it's preventable, it's probably something that we can, cost reduction methods can be applied to. So next is, how do we prevent postoperative AFib? Majority of arrhythmias in the immediate perioperative period are secondary to correctable problems. We know that electrolyte derangements, hypoxia, acidosis, all predispose to rhythm changes. So first thing we should always do is correct these conditions, and I think that's routine practice for most of us. Beta blockers are first-line agent for AFib prevention, and we all know that there's a class 1 indication. And then the role of amiodarone and antiarrhythmics is something that's been thoroughly studied, and the Papa Bear trial is probably the biggest study that supports the role of amio. And we know the pivotal role of inflammation, so medications like colchicine and steroids have been also evaluated. The data is mixed. I know some centers still use colchicine. We know colchicine prevents post-pericardiotomy syndrome, and association likely reduces the risk of AFib as well. And then from the surgical standpoint, there's simple things that we can do, like overdrive atrial pacing if you have atrial wires, but majority of CABG patients don't always come out with atrial wires, so that may not be possible. And we'll look at the role of posterior pericardiotomy and ablation procedures as preventive strategies. So the Papa Bear trial is probably the most pivotal study we have available to support amiodarone prophylaxis. Essentially, this was a study done with patients undergoing CABG, valve surgeries, and what they did was they gave amiodarone at a dose of 10 milligrams per kg in 2 divided doses for 6 days before their surgery and 6 days after. So it was a pretty large dose of an amio loading strategy that they used. The end result was it actually halved the rate of AFib in most of their patients. This data this study didn't really get too much enthusiasm because there's a lot of fear, at least among different providers and surgeons, about amiotoxicity and the effects on the lung and thyroid and all these other side effects that we worry about. But I think for the most part, we are starting to learn amio is relatively safe to give to our patients as it comes to prophylaxis strategy. I do think a lot of centers still have an issue adopting this, and I know most of the institutions that I've worked in, we didn't really do this specific amio strategy. We've kind of come up with our own modified strategy, and I'm pretty sure if anybody has a different strategy or if anybody uses this. Show of hands. Yes, no. Nobody uses it. I see heads being shaken. No. A lot of people were not very enthusiastic about this study because of risk associated with amio. But the main risk, or probably the most limiting factor for most surgeons, was the frequency of bradycardia encountered in the operating room, and a lot of patients were requiring pacing coming out of the OR. So that also dissuaded a lot of people from adapting the strategy. Important thing about amio loading as a prophylaxis is you probably need a minimum of 3-gram load to have effective preventive prevention for atrial fibrillation. So it may not, maybe close to 10-gram load may not be necessary in these patients. This is our institution's modified amio protocol that we adopted in our off-pump CABG patients. So our strategy was to load our patients, if possible, in the preoperative period, a goal being a gram load pre-op, which we never really did because a lot of patients ended up going to surgery way sooner, and we didn't prescribe amiodarone as part of their home medication. But in ideal situations, we like to have a preoperative 1 gram load. In the OR, the anesthesiologist would give a 150 milligram at the beginning of the case and at the end of the case. And if there's no rhythm issues, we would continue amiodarone 200 BID for 15 doses or until the day of discharge. And we saw a moderate reduction in our AFib rates. But I think the most important thing that I want to show you here is not the reduction in AFib, but what happened to patients who developed AFib. So of our patients who had postoperative AFib, majority of them did not require treatment at the time of discharge. So that actually was quite encouraging in our patient population. Next, we'll kind of pivot to surgical strategies to prevent postoperative AFib. The one that's starting to gain a lot of attention is the use of posterior pericardiotomy. It's a simple procedure to do in conjunction with our other cardiac procedures. And this study comes out of Cornell. They did essentially a study of a cohort of patients that were undergoing routine cardiac procedures, and they had a group that had posterior pericardiotomy, and the control was just medical management. And what they saw was a 15% reduction in their postoperative AFib rate by using this procedure. The bonus on top of that is patients who had posterior pericardiotomy did not have or had less readmissions for pericardial effusion as well. So you're kind of hitting two birds with one stone with this strategy. I know some centers have accepted it. Dr. Puskas typically does a posterior pericardiotomies on nearly all of his patients, and that also helped us reduce our AFib rate at Mount Sinai Morningside when he was there. The big, I guess, new idea is this concept of prophylactic pulmonary vein isolation. So the definitive treatment for atrial fibrillation is catheter ablation. But we all know it's not always effective for catheter ablation, at least for management of routine AFib. To be very effective, you really need to catch patients before they start developing structural changes or left atrial enlargement. So the idea is, if you identify high-risk patients who may develop postoperative AFib, and you do pulmonary vein isolation or ablation on them, does that reduce the risk of developing post-op AFib? This was a pilot study that was recently published. They evaluated about 60 patients with a very high CHA2DS2-VASc score, greater than 4, and most of the patients were advanced age, greater than 70 years old, undergoing routine cardiac procedures, and they did pulmonary vein isolation about 29 of these patients, and the remainder were managed with medical therapy. And what they saw was a pretty significant reduction in postoperative AFib rates in those that received pulmonary vein isolation. So 2 out of the 29 patients in the ablation group developed post-op AFib compared to 55% in the medical therapy group. So is this something that we should be offering or doing to all of our patients? That's something that we should see in the near future. I will say that the study reported there were minimal to 0 complications associated with this procedure. Now we'll pivot to management of postoperative AFib. So if you can't prevent it and patients develop AFib, how do you manage it? Well, it's the same as you manage any atrial fibrillation. It's usually the focus is on rate control and rhythm control. So I won't bore you with all those details, but there are, from the surgical standpoint, there are a few things that we can do to kind of mitigate some of the risks that we encounter in patients with post-op AFib. The big issue is stroke and stroke prevention. From medical aspect, the only stroke prevention strategy we have available is anticoagulation. And at least from my experience, this question is always the hardest to answer. It's very surgeon-specific, tends to be very institution-specific. Who do you anticoagulate? when do you start anticoagulation, for how long do you continue it. So really you have to take the anxieties of everybody into account when you make the decision of anticoagulating patients with recurrent post-op AFib. And if you look at the professional societies, they don't even give us a clear universal guideline as to what to use, when to start. Everyone kind of have a variation of recommendations. So typically, we say, you can use at least most surgeons. We don't really bridge with heparin. We may start Coumadin, and we actually started to cheat and started using 2.5 Eliquis on all of our patients, at least until the first week, and we'll get an echo, and if the echo showed there was no pericardial effusion, then we'd start giving full-dose Eliquis for our patients. So everybody has a variation of ways that they handle this question, but the general recommendation is to anticoagulate if AFib becomes persistent or recurrent for more than 42 to 72 hours. And then how long you continue it is, at least a minimum of 4 to 6 weeks. If patients remain in persistent AFib, after that, they should stay on anticoagulation lifelong. I think the best recommendation that I was able to find was out of Cleveland Clinic, which incorporated the CHA2DS2 score to risk stratify patients and decide on who to anticoagulate and who probably would do better without anticoagulation. So again, the cutoff time that they used was 48 hours, but if patients had a low CHA2DS2 score, they opted not to anticoagulate this group of patients because they were deemed low risk. Patients with a high CHA2DS2 score were anticoagulated if they had persistent or recurrent atrial fibrillation within longer than 48 hours. The other important thing that they stress is obviously a team discussion with the ICU surgeons when you start deciding on anticoagulation and choice of anticoagulation, but also getting serial echoes while you're starting anticoagulation to make sure you're not developing pericardial effusions. Surgical strategies for stroke prevention are now the kind of new hot topic that we're dealing with. There's several methods of achieving this. The first trial was actually published in 2018. It's the LAX trial where they did surgical ligation of the left atrial appendage prophylactically in patients who are undergoing cardiac procedures. And they followed these patients out to 5 years, and what they saw was a reduction in stroke rate in patients who received prophylactic left atrial appendage ligation. So that was pretty encouraging. Then the ATLAS trial, which was recently published, used AtriClip to prophylactically clip patients who are deemed high risk, and the risk was CHA2DS2 greater than 2. And so what they saw was, again, a reduction in thromboembolic events in patients who had prophylactic clipping of the left atrial appendage. The LEAPS trial is now the largest randomized trial essentially evaluating the question of left atrial appendage for high-risk patients. It's enrolling in 250 different sites, so hopefully we'll get a clear answer of whether that's the right thing to do in the near future. And lastly, I just want to bring your attention that ERAS has recently published a turnkey order set for management of postoperative AFib. It was recently published in February of this year, essentially summarizing how to manage postoperative AFib in our CABG population and or cardiac patients, cardiac surgical population. The one thing I want to bring to your attention is they're actually recommending the Papa Bear trial dosing of amiodarone. So they're recommending to start amio before surgery and then continuing it after surgery. So I'm pretty interested to see if this is going to be accepted and adopted by most centers. So that's my talk about atrial fibrillation. Anybody has a talk before I move on to other issues? No? Okay. So I won't spend too much time on ventricular arrhythmias other than to say they're bad. We really don't like them. They're increased mortality. But the most common ventricular arrhythmias we see are actually PVCs and non-sustained VTs, which are fairly benign and tend to be related to reversible conditions. So that's why there's not a lot of evidence on what to do about that. It's essentially manage patients and fix problems quickly. Non-sustained VT in patients with low ejection fraction should be carefully further investigated because it could be a sign of problems, so something to be aware. Sustained VT, on the other hand, is pretty concerning in our CABG population, but we also risk stratify it in terms of what type of sustained VT patients are having. Monomorphic VT is usually suggestive of some kind of re-entrant pathway or ischemic reperfusion, like patients who had an MI and now you reperfuse that area, you're likely to see more of a monomorphic VT presentation. It's still bad, but not as bad as polymorphic VT, which, until proven otherwise, is ischemia and requires immediate attention. The etiology of ventricular arrhythmias, like I said, most of the time it's a correctable problem. So it's either hypoxia, electrolyte derangement, acid-base disorders. So quickly identifying these problems and fixing it is the management. And also you have increased endorphins in the surgical milieu. So patients have endogenous endorphins because of the stress of surgery, but we're also giving them medications like epinephrine, dopamine. All of these medications can induce arrhythmias. Amiodarone, which we're giving for prophylaxis, also can prolong QTC and increase the risk of ETs. Ischemia is the big thing we have to worry about whenever we see sustained VT, which again goes with a low cardiac output. And rarely you'll see weird events like, your pacemaker inadvertently paces and you have an RNT event and patients developing arrhythmia for that reason. The management of ventricular arrhythmia is really early cardioversion, right? Even the CALS protocol tells us we can delay CPR and try to shock patients out of it as quickly as possible. In terms of what medications we use, amio and lidocaine, and or most of the time we end up giving everything all at once because that's what we do, but really you just need one, right? But if ischemia is thought to be the primary etiology for ventricular arrhythmias, there is some evidence to suggest lidocaine may be the better drug because it tends to be more cardioprotective. There's still, I think, some old practice of just giving prophylactic lidocaine infusion when you start having a lot of ectopy in the operating room because it's thought to be cardioprotective and helps reduce, protect the heart from ischemic injury. Other things we can try to do if you're having frequent PVCs and non-sustained VT is overdrive pacing. And we should always think of putting in mechanical support, at least in the form of balloon pump, as early as possible. And then the question of when to insert AICD when you're having recurrent rhythm issues is a big problem we deal with, at least in the ICU, in our more complex cases. So I won't go through this, but this is the recommended management of ventricular arrhythmias. I think we kind of touched on most of them. Maybe the one thing worth mentioning is what about non-sustained VT if it becomes recurrent in low EF patients? Should we consider AICD or not? And that I'll talk about in the next slide. So what about AICD? Should we put AICD in patients who are undergoing CABG with the low EF? And this question was evaluated with the CABG patch trial, which showed there was really no mortality benefit in prophylactically putting AICDs in these patients. But a recent study from Japan again asked this question, but more focused on patients who are undergoing CABG with low EF and who have arrhythmia during the hospital stay. Is there a benefit in putting AICD in these group of patients? So it's kind of a retrospective study looking at about 99 patients who had some rhythm problems. Some of them had fatal ventricular arrhythmias, some had non-sustained VT, and some had monomorphic VT. About 55 of these 99 patients ended up getting an AICD, the remainder did not. And they looked at, who did better? Did the patients that had AICD end up having a better mortality compared to those that didn't. A few points to mention is this was a study looking at survival up to 5 years. And in these group of patients, even after revascularization, the most common cause of death was actually heart failure. So their low EF didn't really become normalized. So the majority of these patients ended up dying of heart failure. But the second most common cause of death was sudden cardiac death, which we attribute to arrhythmia. If you look at the cohort that had AICD, they were more likely or less likely to have died from sudden cardiac death. So it was protective to those group of patients. And looking at when sudden cardiac death occurred in this cohort of people, it occurred within the first 6 months of their revascularization. And majority of it happened in the first 3 months, which leads me to the question now. The big debate with our EP colleagues is when to insert an AICD, right? You have a low EF patient who has ectopy or rhythm changes, and what they'll tell you is send them home with a life vest, which we know nobody wears because it's just annoying. So you send them home with the AICD and you don't put a defibrillator in them, and you're increasing their risk of having sudden cardiac death at home. So should we be pushing more aggressively to put an AICD in these cohort of patients? And I think that question is still a question that we don't have an answer to. I will say in different institutions, there are some EP attendings that are more willing to put an AICD. At least in the US, if you put in an AICD, it's not covered by Medicare, so there's always this push not to put an AICD until they're 3 months out of surgery. I'm actually curious to see if that happens in other countries. Anybody? No? Okay. Lastly, conduction disorders. I won't spend too much time. Most of the time, if patients develop some form of bradycardia or conduction disorder, it's very self-limiting, and we don't really need to do much about it other than pace them for the period of time they need support. So that's my piece about arrhythmias. Anybody have any questions before we move to renal failure? Okay. So renal failure is also very common after cardiac surgery. It happens more frequently than we think. So the definition is really not clear, but we know majority of our patients end up getting some form of renal injury after cardiac surgery. This chart kind of shows the mechanism. As you see, it's very, very complicated and hard to understand, and I think that's to make a point. Multiple factors that are at play that may affect the kidney function when patients are undergoing cardiac procedures, especially more complex cardiac procedures. Cardiopulmonary bypass machine use is one of the major risk factors for renal failure, and we know that patients who undergo cardiac surgery with the use of bypass are more likely to have renal failure. It decreases renal perfusion by 30%. Also, the inflammatory response as well as the non-pulsatile flow on pump is not good for the kidneys, and that's all been proven. Also have issues with microemboli and hemolysis that also contribute to acute kidney injury. In the perioperative period, we also have very exaggerated hemodynamic changes which cause hypoperfusion and further acute kidney injury. The use of vasopressors is very non-selective on the kidney, so where you constrict really matters before or after the glomeruli, and that also is thought to contribute to renal injury. There is no clear definition for acute kidney injury. The STS definition is rise in creatinine of 3 folds or higher, or a creatinine of greater than 4, and need for renal replacement therapy is considered a DING and reportable to the STS. Clinically, again, we don't have a uniform definition. It's like one of those things you know when you see it kind of thing. But for the most part, if you have worsening creatinine with oliguria, that's what we consider renal failure. In the literature, though, you'll see the KDIGO definition where they stage kidney failure into stage 1, 2, and 3, stage 3 being severe renal failure and need for renal replacement therapy. They're predictors of renal failure. I think we all know who's at risk. It's usually patients that have pre-existing kidney problems, older patients. Again, the surgical intervention matters as well. The length of time on bypass matters. But there's no clear predictor that we can kind of point to say these are the major risk factors for renal failure. The Cleveland Clinic developed this scoring system to predict renal failure, not renal injury. So the scoring system is pretty helpful if you're trying to predict which patients may be at risk for dialysis after cardiac surgery. Next question is there a way to protect the kidney from the harm of surgery? And not a lot of, I guess, novel ideas are here. The goal is to try to protect the kidney as much as possible by doing little things like avoiding dehydration. This brings into the question of, do we really need to keep our patients NPO for as long as we keep them? Should we let them hydrate themselves? And this concept of carb loading and allowing patients to hydrate up to 2 hours before surgery is being asked. We routinely make sure that we stop nephrotoxic agents like ACEs and ARBs. If patients are cathed and you could delay their surgery for 7 days to allow the kidneys to recover, that's usually a good strategy. If you're at an off-pump CABG center, doing surgery off-pump may be helpful and protective of the kidneys. And then when pressors are being chosen, low-dose vasopressor, because it works on the efferent arterioles, is known to increase GFR and may be kidney protective. Medications like phenoldiprem, which used to be routinely used as a neuronal protective strategy, have fallen out of favor. The evidence is not very strong for them, but they did show some benefit in reducing the need for renal replacement therapy in the patients. And lastly, I still use it. I think it does help, and it rarely causes harm. It's low-dose dopamine, using it to initiate diuresis. It really doesn't help with clearance, but in a subset of patients, it actually does help with diuresis and may get you a day or two to kind of diurese patients without exposing them to other things like dialysis. Another new idea that's come around is the use of biomarkers to detect renal injury early and hope act on it before it becomes more of an issue. The idea here is by the time serum creatinine rises and urine output decreases, you've already lost the majority of your nephrons. So if you have a strategy of detecting renal injury early, then maybe you can be proactive of supporting patients with certain management strategies. The most commonly used, biomarkers are the NephroCheck and cystatin C, and the rest are other FDA-approved biomarkers we have available. So management of acute kidney injury, we're developing this whole concept of goal-directed therapy. What does that mean? It really just means being aggressive about recognizing renal failure and really focusing on the actual, support that they need. And this, in a way, takes us back a little bit. The idea is to focus on, assessing the volume status. In the perioperative period, it's really hard to decide whether patients are under-resuscitated or over-resuscitated because clinically they're volume overloaded. So can we differentiate their volume status a little bit better? Using CVP, if you have a PA catheter, using your numbers from your PA catheter, assessing your filling pressure from there, routinely checking cardiac outputs, even using non-invasive methods to do that, and then using a bedside ultrasound to assess IVC and assess volume status, and deciding whether patients need aggressive diuresis or fluid resuscitation back. And then optimizing your pressors by using medications that tend to be more friendly to the kidney. Like I mentioned, vasopressin is probably the one agent that helps the kidneys. And then majority of our patients, even though they have a normal cardiac function, may need a little bit of inotrope to optimize their oxygen delivery as we see the kidneys struggle a little bit. So being proactive about measuring cardiac output or assessing their ejection fraction and starting inotropes early as we start seeing kidney function being impacted. I think Dr. Engelman has gone over this slide many times. It's their kind of renal attack team that they use at their center. And actually, it's a pretty good strategy. They use the nephro check at that institution. And if the nephro check is normal, they basically do the routine cardiac care where they start diuresis on postoperative day 1 and move their patients along. But if the nephro check is abnormal at their center, they kind of scale back on these patients and reassess and see if patients need more aggressive support with inotrope suppressors, maybe even transfusion to kind of support the kidneys and make sure they don't develop renal failure. And a strategy like this may be what we need for management of renal failure because it is a big problem. It increases morbidity, mortality, and it's something that we deal with every day, which we don't really have a good idea of how to manage. And lastly, the question of when to start renal replacement therapy. For majority of our patients, the indication is when we start seeing electrolyte abnormalities. We try to avoid renal replacement therapy as much as possible in our CABG patients, but there's pros and cons to that. The early renal replacement therapy may be warranted in some patients, but delaying can be, most of the time, is not harmful. So that question in our CABG population hasn't been answered yet. And I think that's the last of my slide. Does anybody have any questions?
Thank you, Michaelia, and we'll be hearing part 2 after our next speaker. I want to call to the podium Dr. Tia Coleman, Senior Nurse Manager of Cardiology. She's going to be going over women and heart disease.
Good morning, everyone. So the topic I'll be discussing today is women and heart disease, and the question is, how do we even think that women had less heart disease than men? This is a topic that's very near and dear to my heart. It prompted me to pursue a career in cardiology. So we'll first look at this slide when we talk about men and women. As you can see, the men are on the top, they have one button, and the women have multiple. So just give an idea of how different men and women are to begin with. So we're going to go back to the past when we talk about women and heart disease. Back in the 1960s, in 1964, the American Heart Association had their first conference for women. However, as you can see, the topic was hearts and husbands, with the agenda of how to treat their husbands' hearts. So heart disease is the #1 killer of women in the United States. The morbidity is half a million women each year die of heart disease. Women are 2 times as likely than men to die of heart attack. So they had a survey that they did that asked women themselves what they thought was their greatest risk of killing them. As you can see, breast cancer was 34%, was their perception. Unspecified cancer was 19%. AIDS was 9%. Heart disease was down at 8%. And ovarian uterine cancer was 3%, when in actuality, heart disease was 37%. Okay, sorry, Okay, I just want to, yes, sorry, perfect. So here are some factors that influence diagnosis of cardiovascular disease in women. They have, hold on 1 second, sorry. Just got a little sidetracked here. Okay, so when you look at men and women, the presentation of chest pain. In men, you have the typical angina, which is a substernal, they're uncomfortable pressure, they feel squeezing, like the typical elephant laying on the chest. The chest pain is brought on by exertion and relieved with rest. Chest pain lasts for more than a few minutes, and it radiates to the jaw or the arm. Whereas in women, they do have typical angina, but it's atypical as well. Shortness of breath is more likely, neck or jaw pain, nausea, palpitations, weakness, fatigue, unexplained anxiety, and only 30% with prodromal chest pain. Okay, symptoms comparisons. Again, as you can see here with chest pain, men are more likely to have chest pain than women. Unusual fatigue, shortness of breath, and weakness, women are higher in that category. Unusual fear and sweating are similar in both men and women. Okay. Are there gender differences in non-invasive diagnostic studying? So by a show of hands, how many have had a family member who has undergone some form of cardiac testing? Or friend or family? Okay, very good. So the first test we're going to start with is stress testing. So stress tests, we have two types. One is exercise, one is pharmacological. It's cardiac monitoring with EKG, or additionally with nuclear myocardial perfusion imaging or echocardiography. For exercise stress testing, in women, it's inexpensive, it's easy to perform, there's low sensitivity though, low prevalence of multivessel disease, inadequate exercise duration, low specificity and nonspecific ST changes in women. MVP has difficulty determining heart disease with women with multiple MVP. LVH with strain, drugs, motion and hyperventilation, and possible digitalis-like effect of estrogen. When we talk about myocardial perfusion imaging, there's radiation exposure. You can have breast tissue attenuation artifact more likely in women than in men. The larger and more extensive defects identify women at higher risk for more severe ischemic heart disease and cardiac events, and negative scans are helpful in excluding ischemic heart disease. For stress echocardiography, there's no radiation exposure. It gives functional information about the heart. Difficult in patients with poor echo windows, for example, with COPD and obesity. Poor sensitivity in single vessel disease. For invasive diagnostic testing, cardiac catheterization is the gold standard. It provides direct visualization of the coronary artery disease. For CT angiography, it looks at the arteries and the chambers. They have high spatial resolution. There is radiation exposure, but it's best in those without coronary calcium. For cardiac MRI, it assesses the function and structure of the cardiovascular system. You can identify infarct, evaluates the blood flow for the heart muscles. There is no radiation exposure, however, it's very expensive. So where are we in the diagnosis of CAD in women? So for women, the major risk factors are age greater than 55, smoking, hypertension, hypolipidemia, family history of premature CAD. When we talk about family history, it's defined as CAD in first-degree relatives less than 65 years old, or first-degree male relative less than 55 years old. Diabetes automatically puts you in a high-risk category. Atherosclerotic disease, CKD, specifically with end-stage renal disease, and family history, like we said. Here we use this prevention iceberg to predict the risk of cardiovascular disease. And as you can see, it's an estimated 10-year risk, and the women get put in categories of low, intermediate, high, based upon their risk factors that they have. So for risk stratification, we have this. As you can see here, we go, like I said, low, intermediate, high, and very high. So for low, it's a less than 10% 10-year risk for coronary heart disease. It may include women with one or more risk factors. For intermediate, the risk is 10 to 20% for a 10-year risk of coronary heart disease. It may include women with metabolic syndrome, especially women over the age of 60. It often includes women with first-degree relative of premature cardiovascular disease. And lastly, it may include women with subclinical cardiovascular disease, elevated calcium scores, and this is not included in the Framingham risk calculations. For high, we have let me go back. Oops. High risk is greater than 20%, so it has a 10-year risk for coronary heart disease events, known coronary artery disease, and carotid artery stenosis. When we talk about modifiable risk factors for heart disease, it's smoking, hypertension, diabetes, hyperlipidemia, physical inactivity, obesity, psychosocial, and medications. These are all modifiable risk factors. So for some guidelines for prevention of cardiovascular disease in women, we use the ALOHA mnemonic to help with determining how to treat them. So for the A, we assess and stratify women into high, intermediate, lower, and optimal risk categories. Lifestyle approaches recommended for all women. Other cardiovascular disease intervention treatment of hypertension, diabetes, lipid abnormalities. It's very important to make sure that we treat all of these conditions to help decrease their risks. For H, we have highest priority in interventions in high-risk patients, and we want to avoid initiating therapies that have been shown to lack benefit or risk outweigh the weight. How do we get results? So we use the ABCs mnemonic. So for the A, we have a simplified approach of CVD prevention to help increase the adherence to guidelines. This can be achieved using the ABCs format to present information, lifestyles, and pharmacological therapies. So for example, anticoagulation, antiplatelets, ACE-ARBs, and anti-anginals. When we talk about B, you want to have tight blood pressure control and start patients on beta blockers. For C, you want cholesterol management and, very important, cigarette smoking cessation. This is very important. And D is diet and weight management, diabetes mellitus prevention and management. So if you have someone who is pre-diabetic, it's very important to try and minimize the risk of them becoming full diabetic. And lastly, for E, you want exercise and ejection fraction assessment. So management goals of ABCs. So again, we talk about the ABCs. For A's, you want to treat all the risks. For the B, you want to maintain blood pressure less than 130 over 85. C, you want cholesterol, your LDL target should be less than 100. D, you want optimal BMI, which includes a diet of low saturated fats, high fruits, vegetables, and fiber. And E, improve physical fitness. We aim for 30 minutes a day, most days per week. If we can do more than that, that's advisable, but at least that's the bare minimum. Okay, now we want to go into some case studies. This first case study is actually a family member of mine, so it's very, emotional a little bit. This is a 50-year-old woman. She has a risk factor of smoking, hypertension, mildly overweight, sedentary lifestyle. She also is a director of nursing, which is a very high-stress job at a hospital in New York. Her symptoms were right shoulder pain. She was actually at a party, dancing. All day she kept saying, her arm is hurting, her arm is hurting. She did go to see the doctor. She said to the doctor, I think it's my bursitis. So the doctor went with that, and didn't pursue any other test. The diagnosis was a massive fatal MI. So the question is, because she presented atypically with the arm shoulder pain, if they had done an EKG, would they have seen ST elevations? We don't know. But the point is, with women, we should always err on the side of caution, and a simple EKG will give you a lot of information. That's step one when you're discussing with anyone in general. Case study number 2, not a family member. This is a 41-year-old woman. No risk factors whatsoever. She's completely fit, no history of anything. She rides a bike 10 miles a day, every single day, except in the rain and the snow. She had slight shortness of breath while she was biking, and she wound up having 2-vessel CAD and had a cabbage ×2. So again, you would not think a 41-year-old female would have any kind of heart disease, but she actually did. So in conclusion, we're still learning about the pathophysiology of ischemic heart disease in women. It continues to evolve. There are atypical presentations. There's more non-obstructive coronary disease with bad outcomes when it comes to women. Chest pain likely represents ischemic heart disease. Diagnostic tests are more complicated in women, and 80% of ischemic heart disease can be prevented with lifestyle changes and risk factor modifications. In conclusion, we should never ignore symptoms in women, do additional testing. If the stress test is negative by imaging and a Duke treadmill score is low, we need to proceed to cardiac catheterization. If the stress test is positive by imaging and cath is negative, we still treat aggressively with aspirin, beta blocker, ACE inhibitors, and exercise training. and we should always risk stratify women aggressively to reduce their risk. So thank you. I want you to spread your word to all your friends and family because knowledge is power, and that helps with prevention. Thank you.
Thank you, Dr. Coleman. We call back to the podium again Dr. Michaela Yemen. She's going to go over part 2 of complications after cardiac surgery.
Okay, I'm back. So the second part of my talk is going to focus on neurologic complications and blood management and bleeding management in the perioperative period. So the most feared neurologic complication for us is stroke. But in cardiac surgery in the perioperative period, we actually see a lot of neurological problems. Some of them are more common than others. And we can classify them into central nervous system problems and peripheral nervous system problems. I won't focus too much on the peripheral nervous system issues, but for the most part, the peripheral nervous system complications are related to mechanical problems, things that happen during positioning in the OR, either harvesting conduits, and rarely in our severely ill patients, we see critical illness polyneuropathy, which is quite common. And is indicative of severity of illness. From the central nervous system standpoint, stroke is the one we fear, but delirium is probably the most common problem we deal with in the ICU. You also have some cognitive disorders that develop after cardiac surgery, especially with the use of cardiopulmonary bypass, seizures induced by medications or related to strokes, delayed emergence from anesthesia, which sometimes confounds our stroke workup in the perioperative period. So I'll focus on stroke and cognitive disorders a bit. Perioperative stroke, at least in the setting of CABG, occurs in about 1 to 3% of our population. Cognitive disorders, like I mentioned, delirium is very, very frequent. And then rarely you have these entities called decline in cognitive dysfunction or a post-bypass syndrome that we don't see that often that impact essentially the quality of life and cognitive function of patients. And it's a very rare phenomenon, and there's not really a lot of data to support whether it's true or not. But some patients have this severe form of cognitive dysfunction. So focusing a little bit on stroke, what are the risk factors for stroke after cardiac surgery, specifically CABG? The main one is the prior history of a stroke and severe carotid disease. And carotid disease is actually one of those that is quite complicated. Majority of our patients have carotid disease, and we don't really know what to do about it, right? When do you intervene? Do you intervene before surgery or after surgery? And there's specific guidelines to recommend when to address carotid disease at the time of surgery. And that's if you have severe symptomatic carotid disease or bilateral severe carotid disease. In those patients, we really should consider intervening, but most patients, we don't really do too much about carotid disease pre-op. History of AFib also increases the risk of stroke. Cardiopulmonary bypass use and the time spent on cardiopulmonary bypass increases risk of stroke. Other comorbidities like tobacco use, renal failure, and a lot of other medical problems also tend to increase the risk of stroke. We don't really have a good strict stroke predictor model. The one that is sometimes helpful is the STS risk calculator, which gives you a % risk of stroke after a certain type of surgery. We don't really pay attention to it, but I do think that's an important point that we should focus and really risk stratify our patients and decide if surgery is the right thing for them if their stroke risk is much higher. And you'll see here just common risk factors for periprocedural stroke listed here. specific to CABG and common cardiac procedures. In this table here, you'll see stroke rates per procedure, surgical procedures and percutaneous procedures. What I want to bring your attention to is how low the stroke rate is in percutaneous procedures, right? PCI, the stroke rate is less than 1%. TAVRs now have actually gotten pretty good, and their stroke rate associated with that is less than 3% compared to isolated AVR, which can be up to 5%. So risk stratifying our patients and doing what's best for them, is very important, because a stroke can be a devastating complication that changes the quality of life of our patients. So the most common time strokes are diagnosed in the perioperative period is actually at the time of awakening from anesthesia. And the reason for that is the mechanism of strokes and cardiac procedures. Most of the time, the stroke actually happens during procedure and is thought to be related to a microembolic event. Majority of perioperative strokes are ischemic strokes related to microemboli, but rarely in patients with severe peripheral vascular disease, you can get hypoperfusion to areas of the brain as well. And then hemorrhagic stroke is always a risk, especially since patients are being anticoagulated with high doses of heparin. So the question of microemboli was actually studied by, and I'll present this. I'll present this study. It's Dr. Taggart's group that did this elegant study published in 2004. So they used a fancy transcranial Doppler called a multi-frequency transcranial Doppler, which was able to differentiate between artifact, solid matter, and gas. So they monitored patients undergoing different types of cardiac procedures, off-pump CABG, on-pump CABG, and open cardiac procedures throughout their whole surgery. And it was an automated machine, so it was able to pick up signals as the blood was circulating through the brain. And what they showed was essentially studied the embolic events, whether it was gas or solid. What they showed was, at least in off-pump CABGs, the risk or the frequency of embolic events was much, much lower as compared to on-pump cases. And as expected, the highest microembolic events on-pump cases was at the time of aortic manipulation, whether it's during cannulation, coming on or off bypass, or doing your anastomosis. So this study supports off-pump is less likely to have stroke complications, and that's a big topic that we'll try to address in the next slide. So again, is there a benefit in doing off-pump versus on-pump surgery in terms of stroke risk? The big trials did not show this, right? Again, a lot of smaller randomized studies have actually showing reduced risk of stroke in patients undergoing off-pump procedures, as well as the other risks that we mentioned here. Now, there's a huge discrepancy between the large randomized control trials comparing on versus off-pump, and that's an active discussion that's going on. But in a way, I think we should trust the smaller studies, because doing an off-pump procedure is a commitment, right? You can't just do it once in a while. You really have to do off-pump routinely to get good at it, because it requires a learning curve. And to get good outcomes doing off-pump procedures, I think routine use of this technique is very, very important. And maybe the centers that do the most off-pump CABGs are probably the ones that have more accurate, outcome data that we should rely on. At least that's my take on it. This study actually looked at off-pump CABG of different variations to see if one type is better than the other. So there's many different strategies of doing off-pump CABG. There's the conventional approach, where you still require at least partial aortic cross-clamping, and then newer strategies of using devices called proximal anastomosis device, where you avoid aortic cross-clamping by just creating a hole in the device, either automatically sews your proximal anastomosis, or allows you to do it yourself by essentially blocking the blood coming out of the aorta. And then there's also the no aortic approach where bilateral mammaries are used and the aorta is not touched at all. So they compared these three strategies to see if the stroke rate was different, and the result was, of course, that no aortic approach showed significant reduction in stroke rates. So when we do these comparison studies, it's probably important to kind of differentiate which type of procedure is being used, and larger studies didn't really differentiate between the off-pump cases or procedures that were being done when they were comparing outcomes. So a no aortic touch off-pump procedure probably is the best approach for patients who we deem at risk for stroke, if it's available at our centers. We'll talk briefly about delayed emergence because this is one problem that we face not too infrequently, and it's really concerning when you see it because you don't know if your patients are having a stroke or they're just still under anesthesia. This phenomenon is thought to be because some patients have delayed metabolism of certain types of anesthesia, and the most common culprits are benzodiazepines, narcotics, and paralytics. And now I think with this whole fast-track extubation strategy, we're all trying to reverse things quickly, so we're seeing it less and less. Most patients are getting reversal agents either in the operating room or on arrival to ICU to facilitate fast-track extubation. So delayed emergence, we see it often, but it's not a problem that we encounter that frequently. But there is a subset of patients that don't metabolize anesthesia very well, and when we do encounter them, it's very confusing because you're always worried about a stroke and you don't want to miss it, and it's a bit challenging. The most of the time they wake up, they just may need a little bit more of additional support, and then reversal agents, the majority of the time, do help emerge them from their anesthesia. The other spectrum of that is emergence delirium. Like there's a group of patients that just wake up like a china in I forgot the synonym, but they're very aggressive and delirious, and these groups are also a little bit challenging to manage. Which leads me to the next talk, which is delirium management, which is a big issue in the perioperative period. A majority of our patients are suffering from this, and a bulk of the problem is really us and not them because we are not managing sleep cycle and nutrition and things that matter in the preoperative stage and the immediate post-op period very well. Delirium risk is more than 50% in the ICU, especially when patients are in the ICU for a prolonged period of time. Risk factors are advanced age, pre-existing history of mood disorder or cognitive disorder, history of substance use or risk of withdrawal, sleep disturbance. We really don't let our patients sleep, and we're constantly waking them up and disrupting their sleep. Infections and complicated perioperative course. Narcotics are notorious for causing this, as well as benzodiazepines. And malnutrition is probably the most important point that we don't address in the preoperative period, which is a major risk factor for delirium. The pathogenesis of delirium in cardiac surgery is not quite understood, but we think, again, systemic inflammatory response related to cardiopulmonary bypass likely plays a role. Temperature dysregulations may also impact delirium outcomes. Obviously, correctable problems like hypoxia and hypoperfusion. The non-pulsatile blood flow during bypass is probably not an ideal way to perfuse the brain, and maybe that's some injury that's caused by that. And then there's always ischemic reperfusion injury, especially in long, complex cases that may impact the function of the brain and lead to increased risk of delirium. The intraoperative and postoperative predictive factors are listed here, and again, most of them are related to complexity of surgery and severity of illness. The main ones that we can control are sleep disturbance issues, pain management issues, and then avoiding problems like infections and other post-op complications. Drugs to avoid in the perioperative period are medications like benzodiazepine and Benadryl, and then narcotics. If we can minimize our narcotic use, we can also decrease our delirium complications. The management of delirium should really be broken down into 3 phases. We really should focus on the preoperative stage because that's where we have most of the control, especially for elective cases. I think that's where we should do more research and more support of our patients. Every institution should adopt a delirium screening tool. There's many available and many have been published. And then really focusing on improving nutrition pre-op, prehabilitation as much as possible, addressing substance use, especially alcohol and smoking, and then screening patients for cognitive disorders and having a frank discussion with family about the risk of delirium in the perioperative period because it's very, very distressing for family members to see a delirious patient, right? It's routine for us, but it's probably the one thing that family members have a very bad outcome or experience with. So focusing on the pre-op part is probably a key important point that we should focus on as we manage our patients. And during the intraoperative period, several strategies have been, suggested or looked at. Obviously, if we can avoid cardiopulmonary bypass use by doing off-pump procedures, that probably will help the rates of delirium, or minimizing cardiopulmonary bypass use whenever possible. Maintaining cerebral perfusion, I'm pretty sure it's routine and standard, but a continuous cerebral pulse oximeter monitoring should be a key part of anesthesia, and I believe it is in most operating rooms. And then the depth of anesthesia is also important. Putting people into a deep anesthetic state actually increases their risk of delirium and cognitive dysfunction. So having a BIS monitoring during anesthesia to give patients more of a tailored anesthetic support during their surgeries and minimizing drugs as much as possible. Several sedative and anesthetic agents have been evaluated in terms of their risk-benefit for delirium, and Precedex obviously is probably the best medication to give to avoid delirium, but also to treat delirium in the perioperative period. Ketamine has been looked at, and to be honest, as a treatment for delirium is probably not a good medication, but as an induction agent, it actually has shown to be beneficial in minimizing risks of delirium. Most centers that I've worked in that do fast track or ultra fast track extubation use ketamine as part of their anesthesia, and patients actually wake up with pretty impressive emergence delirium. And it's very distressing for everybody. It's distressing for the ICU because we're like, oh my God, they're going to reap their chest, blah, blah, blah. The family's all distressed. But the next day, they actually tend to do much, much better. And I haven't quite understood the role of that, but ketamine is one of those that probably should be further studied. In the postoperative period, the key here should be adopting a delirium reduction bundle, which focuses on sleep hygiene, nutrition, and early mobility. Those are the key things that get our patients out of the ICU and allow them to have the minimal complication of delirium. Pain management is key here, and with ERAS now, most centers are trying to minimize narcotics by using non-narcotic pain therapy like Tylenol and NSAIDs when possible, and medications like Lyrica or gabapentin. And then reviewing the prior history and kind of instituting medications that are necessary and that could support the cognitive function is also key. When to start if a patient develops or has a complication of delirium, what agents to use is always a question. I personally don't like these long-acting antipsychotics in the immediate, postoperative period. I tend towards giving Precedex because they're in the ICU and we can quickly turn it on and off. But antipsychotics like risperidone, olanzapine, and Haldol have actually shown some benefit. Not really quite a supporter of Haldol because, again, it's one of those medications that prolongs your QTC, and then the perioperative period may increase the risk of QT prolongation and arrhythmia. There is insufficient data to say that there's prophylactic medications that should be started. I think the only medication worth considering may be melatonin to help our patients get a better night of sleep whenever possible. But melatonin doesn't work if we don't keep interrupting them. So bundling our care, especially at night, from a nursing perspective and trying to kind of minimize and interrupt sleep disruption is probably the key. Another part of this delirium bundle reduction is simple things like addressing visual disorders and hearing disorders in our patients. So especially for elderly patients that have hearing disorders, making sure that they get their hearing aids as early as possible, getting their glasses to them as early as possible so they don't have, they're aware of their environment, and then frequently reorienting them just to make sure they're comfortable in their situation. And lastly, if we don't do it, at least from the sleep hygiene perspective, providing our patients simple things like earplugs and sleep masks also helps reduce the rate of delirium. So these are non-pharmacological techniques that we can use to reduce the risk of delirium. So the next part is blood management and bleeding management. So I'll try to review some of the highlights of these 3 recently published guidelines in terms of blood management and bleeding management. And I'll try to also kind of give my take on how we manage a postoperative AFib and the new ideas that are being floated around. So I'll break this section into 3 categories: the preoperative period, which I think is very, very important and probably underutilized, the intraoperative period, which relies heavily on our anesthetic colleagues, and then the postoperative period, where we focus on minimizing transfusions and bleeding management. So in the preoperative period, this is probably the most important period for our patients. The goal here should be to recognize patients who are at risk for anemia or who have anemia, patients that may be at risk for transfusions, and then obviously that have increased risk of bleeding, and to address these problems before they go to surgery. Especially in non-emergent elective cases, we really should optimize this time to correct these problems. Certain type of tests to check as well that may help us risk stratify bleeding include fibrinogen level. A low fibrinogen level is actually associated with increased risk of postoperative bleeding. So not that we're going to replete it, but it actually signals us to be more cautious in these patients. Anemia management should really start very, very early, depending on what medications you use. And as shown in this chart here, anemia and transfusion are major risk factors for adverse outcome in our cardiac surgery population. So there's a 40% risk of increased adverse outcome in these cohort of patients after cardiac surgery. And it's really a spectrum of problems that you see here, for pulmonary complications to wound problems, as well as renal failure and even death. So we want to optimize this as best as possible and as early as possible. Unique to cardiac surgery is most of our patients are on some form of antiplatelet therapy. So management of this is one of the first steps. And there's recommended guidelines of what to do with certain types of antiplatelet therapy. Aspirin routinely is kept on, and we don't interrupt aspirin therapy prior to cardiac surgery, with the exception of 2 categories of patients. One is patients deemed to have a high risk of bleeding, whether that be they have underlying congenital hemophilia or platelet dysfunction, or patients for religious or personal reasons refuse to take blood products after surgery. And those cohort of patients, probably ideal to stop aspirin at least 5 days before surgery for urgent and kind of planned elective cases. For everybody else, aspirin should be continued and is thought to be protective. And P2Y12 agents, depending on what agent the patient is taking, should be interrupted for a minimum of 3 to 7 days. the most common, I guess, P2Y12 agents we deal with nowadays are Plavix and Brilinta. At least in the US, Brilinta is probably the most favored P2Y12 agent by cardiologists because it tends to have certain characteristics that the cardiologists like. It has a faster onset and offset, doesn't require metabolic activation, and tends to have a consistent platelet inhibition. So for most interventionalists, they tend to start their patients on Brilinta. The good news is it's the only P2Y12 agent which has an antidote that was recently introduced. So we'll talk about that in the next slide. But despite the recommendations of stopping these agents as listed here, every patient metabolizes P2Y12 agents very differently. So if you have a platelet function assay in your institution, it's probably a good idea to use it routinely to help you optimize the timing of surgery. Sometimes you find out that patients are non-responders and you can take them to the OR sooner. Other times you'll see the effects of these medications lingering on longer than expected. I mentioned the antidote for Brilinta. This is a new monoclonal antibody called bentracimab that was recently introduced. And this study looked at the effects of this medication and how quickly it reverses the ticagrelor. So they used it on 150 patients who needed either urgent surgery or a reversal for major bleeding complications. And this medication actually was quite effective. It reversed the effect of Brilinta within 5 to 10 minutes, and the reversal actually lasted up to 24 hours. The limitations were, one, there was increased risk of thromboembolic events. There were some arterial occlusions that were, as well as strokes that were reported with its use. And I think the big limitation, at least from the cardiac surgery standpoint, is it actually required, the infusion of the medication required a minimum of 15 hours. You have to give a loading dose, then an infusion, and blah, blah, blah. So it really takes, it's a very long infusion, and it's not quite practical for our emergent cases. So its utility is still questionable in the cardiac surgery world. Anticoagulation is something that we routinely deal with, and the most common anticoagulant we deal with is heparin, and I think everybody's pretty comfortable with management of heparin. We rarely use low molecular weight heparin in the preoperative period, but if you do, these are the recommended times when you should stop them. Vitamin K dependent antagonists like Coumadin should be stopped a minimum of 5 days, or at least until the INR is less than 1.5, and depending on the indication for anticoagulation, sometimes we may need to bridge our patients with heparin. And then the new, excuse me, the direct oral anticoagulants, as you see here, the recommendation is actually to stop them for 48 hours, but at least in my institutions, we're very, we're very scared of them. We typically stop them for a minimum of 3 to 5 days. We never really just stop for 48 hours. But we also have antidotes available for these agents, so if urgent or emergent surgery is needed, we can always reverse these medications. If you don't have Andexxa available in your institution, you can also use PCC for reversal of most of these medications. We'll move to preoperative anemia management, which I think is very important in our surgical population. As we mentioned, anemia is associated with increased adverse events, such as cardiovascular events, need for transfusion, which is also associated with increased mortality, and then bleeding complications, renal failure, and death. So we really want to manage anemia as best as possible in the preoperative period. Anemia workup should be part of our routine preoperative evaluation. And the most common cause of anemia is iron deficiency, so we should correct that as much as possible. So what should you give for anemia management? We know oral iron is not very well tolerated, and it takes a very long time to work. So the recent recommendation is actually to give patients an IV infusion of iron. preferably 1 to 2 weeks before surgery, and this should be kind of standard of practice for most of us. At least in the US, this is a bit challenging because most insurance companies won't pay for infusion of iron, but that's something that we should advocate for pretty aggressively. The new game changer is actually EPO, which should really be used on everybody, and I'll try to convince you why. EPO increases red blood cell mass, and several studies have actually showed improved outcome in patients who received epoprotein in the preoperative period. The idea is nearly all of our patients undergoing cardiac surgery will have some degree of ischemic renal injury, and epoprotein is produced by the kidneys. So we expect that, and there's always some blood loss that's associated with cardiac surgery. At the time when they may need EPO production, they may not be able to produce this because the kidney is injured. So prophylactically giving them epoprotein is probably a good idea to help boost their red cell mass production. In addition, recent studies have actually shown epoprotein to be cytoprotective, especially on the kidney, brain, and heart, the 3 major organs that we worry about after cardiac surgery. Was this whole belief that it increases cardiovascular risk and it was harmful, but that has actually been disproven. It's a very safe medication to give and should be part of our treatment strategy for management of anemia, but also in non-anemic patients, it's actually shown to be beneficial. So hopefully this is something that we will adapt in the management or support of our patients. Blood management in the operating room heavily relies on our anesthesia colleagues, but I'll go over some strategies that have regained popularity and things that we should consider doing at least in some of our patients. The main one is the use of acute normovolemic hemodilution. This is a strategy where you take, at least in non-anemic patients, and preferably in patients who can tolerate some degree of anemia during cardiac surgery, removing 1 to 3 units of blood and before you heparinize them, and then giving that blood back after their cardiopulmonary bypass run. The idea being you're kind of protecting some of their own blood from being exposed to some of the harms related to cardiopulmonary bypass and activation of clotting factors and things of that nature. The limitation to this is it requires planning, and then you have to be able to tolerate some degree of anemia, especially on patients that are undergoing cardiopulmonary bypass support. So this strategy, I know at our institutions, is something that we routinely used in young patients who are found to be not anemic, and it really helps us avoid not only transfusion risk, but also bleeding risk, and it's a strategy that hopefully should get adopted by most institutions. The role of fibrinolytics has actually been thoroughly studied, and that's something that most centers have adopted. Medications like Amicar or TXA should be given routinely in the operating room using a continuous infusion and then continued in the ICU or rebolused as needed in the ICU. They've been shown to decrease the rate of transfusion, but also bleeding complications in our immediate postoperative period. And then viscoelastic testing and point-of-care hemostatic testing has become very, very crucial in managing postoperative bleeding, but again, giving targeted blood transfusions instead of just giving blood products without knowing what the patient needs, using these tests to help you kind of narrow what's deficient in patients is something that's being done routinely in the ORs and something we're adopting in the ICUs. So viscoelastic testing is actually a very, very old test. It was first introduced in the 1950s and 50s, and now has gained a lot of resurgence. There are several types, TAG and ROTEM. And what these tests allow you to do is do point-of-care testing of your coagulation profile and allow you to kind of identify what deficiencies you have and the coagulation cascade. They give you very timely information because they're done in the OR or ICUs, and you don't have to send the blood to the lab where it's abyss. Sometimes you get your results, sometimes you don't. And more importantly, it's the targeted therapy part that is very important with the TEG or ROTEM. Post-operative bed management really focuses on two things. One is anemia management in the perioperative period, and the second part is bleeding management. In non-bleeding patients, we really should be accepting more restrictive transfusion parameters, right? If patients have minimal symptoms, it's okay for them to have a hemoglobin of 7 and kind of support them through it without just jumping to the gun and giving them transfusions to correct a number. We really should be treating symptomatic anemia and not just a number. And this is a culture that's slowly changing in cardiac surgery. Before, if the hemoglobin was less than 8, it was like a routine to just keep on transfusing patients. But we know transfusion increases mortality, and one of my mentors used to say, blood transfusion is a blood transplantation, right? You're giving somebody a lot of antibodies, so you really should think about it before you give blood products that are unwarranted. And several studies have actually showed non-inferiority with more stricter transfusion guidelines. The management of bleeding it can be a bit complicated in the perioperative period. So I think the key point in bleeding management is communication. So in my opinion, every institution should adopt a bleeding algorithm that everybody's aware of, so it becomes standard and routine, and expectations are met in a timely manner. It also promotes early recognition of bleeding. It avoids excessive transfusions. We should always incorporate these new viscoelastic testings in our bleeding algorithm because they allow us to focus on the deficiencies and not just keep on transfusing blood products without knowing what the patients need. Again, maintaining tube patency is also key. And to stress again, communication is actually the most important part. There are several transfusion algorithms, but this is the one we developed for our institution. And the key point that I wanna make here is, your threshold for bleeding. Everybody has a different threshold. Our threshold was pretty aggressive. Our routine in the ICU was to document bleeding every 15 minutes for the first hour, and then if bleeding occurs, we continue doing it. If not, we scale back to every 30 minutes. So if we noticed the patient had a chest tube output greater than 30 cc's for 2 consecutive 15 minutes, that kind of triggered our alertness, and we were on top of that patient and tried to correct whatever was correctable. And we used some, old kind of voodoo strategies like increasing PEEP, and they usually don't harm. So we basically used everything we had under our armament to stop bleeding as early as possible, because this allows us to control not only the bleeding, but minimize unnecessary transfusions and improve our outcomes in terms of bleeding management. Key part of this algorithm was constant communication with the surgical team. Obviously, if there was a concern for a surgical bleed, patients were addressed right away, but if bleeding continues and we felt like, we didn't really quite understand what was going on, we, again, touched back with the surgical team. Vice versa, I think communication between the surgical team and the ICU is very, very important. There's a lot of kind of hidden information we discover, late after things happen, but being transparent about the concerns in the operating room so the ICU team is aware is actually very, very important in managing complications in the perioperative period. Bleeding management is really focused on effective clot formation. Clot is essentially a combination of platelets, blood, and a matrix of fibrin, right? So optimizing all these things is very important. And having an imbalance in the clotting cascade is usually the most common cause of what we call medical or microvascular bleeding. So the most common causes of microvascular bleeding are these four things. Either you have a platelet dysfunction, you have an inhibitor that you haven't recognized, the most common thing being heparin rebound, a factor deficiency, or you have clot breakdown where fibrinolytics are important. On the other spectrum, when you start giving products, the complication you worry about is excess clotting, right? Hyperactivity of your platelets and inability to break down clots. So it's a balance between these two factors that we're trying to deal with. The tools we have in bleeding management are the ones you see here. TXA or Amicar are the common fibrinolytics we use. Calcium is actually under-evaluated, but it's very important, not only in the activation of platelets, but activation of factors, so making sure you don't deal with hypocalcemia in the immediate postoperative period. I'll briefly talk about the role of PCC and fibrinogen concentrate in the next few slides. And then the blood products we routinely give are cryo to replenish fibrinogen, obviously red blood cells and platelets to replenish those appropriately. And then plasma is where we get most of our factors, so to replenish factor deficiency, we give plasma. This is the intrinsic and extrinsic pathway, which I try to forget all the time, but keeps coming back. And just to show you where these things work, DDAVP, we routinely use it in our whenever we have concern for bleeding, because most of our patients are on aspirin, and that causes platelet dysfunction. So routinely given in patients who are thought to have platelet dysfunction, either related to aspirin or renal failure, and it activates the von Willebrand factor, which then activates the platelets, right? And then the synthetic fibrinolytics help you prevent breakdown of your clot here, platelets and cryo we mentioned already. What about these factor supplements? PCC is a combination of factors, the vitamin K dependent factors, and there are several types of PCCs available in the market. And then Novo 7 is factor 7, which is available. And then fibrinogen concentrate is something we don't typically use in the US, but probably a better way of replenishing fibrin as compared to cryo. When someone is bleeding, the hardest thing for us is getting cryo because it needs to be thawed, and it takes the longest time to get to the bedside. So maybe using fibrinogen concentrate is probably a better idea, and several studies have actually shown its utility in cardiac surgery patients. Factor supplements, there are several of them available in the market. The two common ones we use, at least in the US, are Kcentra and FIBA. There's minor variation in these two, and I think it becomes very person dependent. Some people like Kcentra, some people like FIBA. The difference between them is Kcentra is thought to be more of a balanced factor supplement because it has procoagulants and anticoagulants, so it has some heparin in it. So just be aware you can't use it in patients with history of HIT. Novo 7 is probably the most feared factor that we have available. It's been associated with increased thrombotic complications, so unless it's for salvage bleeding, most people would never entertain using it in cardiac surgery. And then I mentioned fibrinogen concentrate here to replenish fibrinogen. So I'll talk about, the role of PCC and salvage bleeding management in cardiac surgery, which has become pretty routine, at least in the centers that I've worked in. We're using it very often in valve and aortic surgeries as part of our blood therapy, not even to prevent bleeding, but at the end of the case, and the institution I'm in, most patients end up getting FIBA or Kcentra at the end of the case, and we're seeing the reduction in transfusion needs in these patients. The role in CABG patients is still debatable because of the increased risk of thrombosis and graft failure, and I'll show you some data in terms of that. This was a study that prospectively used a prothrombin concentrate complex versus plasma in patients undergoing cardiac surgery. So the study design was at the end of case, once heparin was reversed, if the surgeons were concerned about microvascular bleeding, they put patients into two arms. One arm got plasma, and the other arm ended up getting PCC. And in this study, they showed that there was really no thrombotic complication, which is the main risk we worry about. And then there was effective control of bleeding in both groups. And the PCC group tended to have reduced need for blood transfusion. So good outcomes, or at least no harm was seen by giving PCC for management of bleeding in the operating room. I will say that majority of the cases in this study were non-coronary cases. They were valve and aortic cases. This is a study from North Shore University Hospital where I'm working, where we routinely use FIBA as one of our PCC agents. And it's a study, a retrospective study looking at patients that received FIBA for salvage bleeding, and these were all CABG patients. So they gave FIBA to 63 patients who were actively bleeding. Instead of re-exploring them, they were administered FIBA, and they looked at outcomes in terms of graft failure and thrombotic complications. And you'll see there was no reported thrombotic complication, and none of the patients needed revascularization. They obviously were used for salvage, so the blood transfusion requirement is not very important in this patient population. I will tell you that some of our surgeons are actually becoming more comfortable using FIBA and CABG, and we haven't really seen much complications in terms of graft failure, and this may be something that may be routinely used in our patient population. That's the end of my talk, and any questions? Okay, thank you.
We have our next presentation, Dr. Bat and Dr. Sharit, who's going to go over ERAS.
Thank you very much for having me here. I am going to switch gears a little bit and talk about enhanced recovery for cardiac surgical patients. Now, for those of you that were at the last session or the last lecture, Dr. Yemin talked about a few of the initiatives, and you'll see that a lot of them have taken form in the name of an enhanced recovery model. However, I'm going to particularly, as an anesthesiologist, what is dearer to my heart, which is pain management. So we're going to go ahead and look at different types of models. I'm going to talk a little bit about enhanced recovery and then, of course, pain models. So here are my disclosures. So again, just to give you a little bit of an idea, so I'm going to talk a little bit about what is cardiac-related pain. It's a little bit different than other surgical procedures. I'm going to talk about opiate use and how it truly is still an epidemic in this field. And what is, when you say chronic pain, what does it mean in cardiac patients? I'm going to discuss what the enhanced recovery model in cardiac really looks like, as opposed to enhanced recovery models that are in general surgery, where they have more robust data. And then, of course, I'm going to talk about what is near and dear, as I said, is multimodal analgesia, with the inclusion of course, how it relates to ERACs. Following myself, Dr. Ali Shariat, who's a regional anesthesiologist, will be then talking specifically about the regional anesthesia component in multimodal analgesia, which is, of course, unique to something that we bring to the table. So first and foremost, cardiac anesthesia can be associated with significant post-op pain. And you can essentially categorize it within about three main types. There's acute pain, and it's most commonly related to the initial inflammatory response. It's often it's a response to the incision, the retraction in the case itself. It's mediated by local and systemic inflammatory mediators, and if it's treated correctly, it will often resolve in the first few days. Then there's neuropathic pain. Neuropathic is basically the neurogenic inflammation, and it's often due to the stretching or actual direct injury to the nerves themselves. It can be temporary, or it can have sustained pressure. This pain can be immediate or unfortunately develop over weeks or even months for that matter as these severed nerves start to grow. Sometimes they grow abnormally and they become trapped in scar tissue. Particularly when you're looking at the visceral and the parietal pleura, they're quite sensitive to these pressure and stretch related stimuli. Furthermore, there's many studies that have shown that harvesting the internal mammary artery have been linked to this neurogenic pain syndrome post-surgery, and this could be months after cardiac surgery or sternotomy. And the last but not least, which is it's rare but unfortunately something that can happen months and months out, is PPS or post-sternotomy syndrome, post-pericardiotomy syndrome, and it's a heightened immune response. Unfortunately, patients present with vague symptoms like chest pain. They can have a pericardial rub, they can have pleural or even, for that matter, pericardial effusions, and this can begin sometimes in the first post-operative week, but it can actually, unfortunately, present months and months later. Most importantly, all of these factors can lead to chronic pain syndrome, for which chronic opiate or continued opiate use is required. So here's a nice cartoon, but it really gives you an idea of the multiple sites of incision in cardiac and cardiothoracic surgery overall that can be associated with post-op pain. And unfortunately, as you can see, that when patients present with pain after cardiac surgery, it's not always easy to identify where it's coming from. So not only can this pain be quite severe, but it can last a very long time, leading to chronic post-sternotomy pain syndrome. Now, here's a study actually looking at pain over a year after cardiac surgery. So what they found was at post-op day 4, almost half of the patients still had pain at rest, while with motion or coughing, the pain was up to 78%. What's even more interesting is that even at a year, persistent pain was experienced by 24% of the patients with any sort of motion. So now opiates have always been the mainstay of cardiac anesthesia. They still are. But it's due to the better hemodynamic profile, and it's reliable. There's tons of studies dating back to the 60s and the 70s, even about how opiate and opiate therapy is very reliable in cardiac anesthesia, cardiac surgical patients. However, persistent pain requires opiates, unfortunately, and this can often lead to opiate dependency. Now, here's a very large study by Brescia et al. That looked at over 24,000 opiate-naive patients undergoing cardiothoracic surgery, just to determine what persistent opiate pain use is. New persistent use was defined as continued prescription filled after 91 days. What they found is that new persistent use was found to be in 13% of these opiate-naive patients. And not surprisingly, the persistent use was doubled with the greater prescription number. Here's another study by Brown and colleagues that looked at over 35,000 opiate-naive CABG patients and valve patients, of course, and they found that it was the persistent opiate use was up to 9.6%. Again, persistent opiate use defined as prescriptions filled after 90 days. What they identified, though, they identified certain risk factors, which included CABG surgery compared to valve surgery, as well as younger age, female gender, pre-existing comorbidities such as congestive heart failure, lung disease, kidney failure, diabetes, of course, chronic pain and alcoholism, as well as any preoperative use of not only opiates, but also benzodiazepines and muscle relaxants. So what about patients who are opiate dependent? Well, here's a study looking at 330 patients who underwent CABG surgery to determine chronic opiate use in opiate-naive versus opiate-exposed patients. The chronic opiate use was, again, defined as usage beyond 90 days after discharge. And what they showed is that opiate-exposed patients were prescribed higher doses, they required greater refills, and had a significantly higher percentage of opiate dependency. Furthermore, and not surprisingly, these opiate-exposed or dependent patients have a higher rate of complications. Here's a study that looked at patients undergoing, again, cardiac surgery, and what they found with the patients who had opiate use disorder, or otherwise known as OUD, persistent use, who underwent cardiac surgery had a much higher rate of overall complications, and this included things like transfusion, longer mechanical ventilation, pulmonary embolus, and prolonged, of course, pain syndromes. The same group, Brescia et al., actually looked at over 2,000 patients, again, opiate-naive patients, in patients undergoing lung resection, just to determine, again, persistent opiate use. It was again defined as any prescription filled after 91 days. So new persistent use was found to be in 14% of these patients, with a higher rate in, of course, patients who underwent thoracotomy and any adjuvant therapy. Not surprisingly, the persistent use was greater with the greater prescription size. As a matter of fact, when you look at thoracic surgical patients or patients who undergo thoracotomy, and the reason why I include thoracotomy is because minimally invasive cardiac procedures are also done via thoracotomy. So patients who underwent thoracotomy are at higher risk for significant early post-op pain intensity. And this, of course, is a huge risk factor for leading to chronic pain syndromes. A meta-analysis of chronic pain after thoracotomy reported an incidence of 57% at 3 months, 47% at 6 months, and 43% at 12 months. Importantly, these studies highlighted that thoracotomy, or patients who undergo any sort of procedure via thoracotomy, have the highest rate of new persistent opiate use after surgery compared to any of their other surgical cohorts. In 2019, colleagues at Hopkins analyzed the Truven market scan and determined that persistent use, opiate use, in CABG was about 8%. Other than looking at persistent pain, persistent opiate use, they defined certain risk factors. Now, besides perioperative exposure to opiates, the other risk factors they defined were persistent opiate use prior, tobacco, lung disease, female gender, comorbidities like anxiety, and of course, as I said already, prior substance use. While most of these risk factors are not immediately modifiable, the one that we have the capacity to change here is the prescription of opiates. As a matter of fact, these authors saw, after analyzing all of these patients, that for every 100 MMEs or morphine equivalents of increase in opiate prescription, there was a 17.2% increase in risk of persistent opiate use. So now one solution to this opiate crisis may be the implementation of multimodal analgesia within an enhanced recovery care model for cardiac surgical patients, which I'm going to refer to as ERACs. Now, many of you already know about enhanced recovery, and I'm sure are using some sort of care pathway model at your hospital. So, but just to define this, ERAS is a multimodal, multidisciplinary care pathway to achieve early recovery in patients undergoing cardiothoracic surgery. Now, when you look at these patients, the increasing sort of patient expectation, the complexity of cardiothoracic patients, surgical patients, and the growing, of course, elderly population makes this patient a sort of ideal cohort for enhanced recovery, even though it hasn't really gained as much speed and as much popularity as some of the other surgical subspecialties. Also, more importantly, clinical trials have also shown that a well-designed and implemented ERAS program can assist in reducing postoperative complications and cost, and of course, leads to much better patient satisfaction. So now, when you look at enhanced recovery, this is not a new concept in cardiac surgery. As a matter of fact, here are 2 older studies looking at the implementation of ERAC's components in cardiac surgical patients. They date all the way back to 1994. Now, when applied to cardiac patients, it has been shown, both of these studies showed that it's not only feasible to apply these concepts to cardiac surgical patients, but more importantly, it decreases postoperative morbidity in cardiac patients. As a matter of fact, the ERAC Society released its first consensus expert review guidelines outlining these components and implementation in cardiac surgical patients back in 2019. Now, before I get into the multimodal analgesia, ERACs is not just one concept. It is the whole perioperative process, as I stated earlier. It consists of multiple components that can benefit especially this group of patients. More importantly, it addresses the whole, not only perioperative period, but you're looking at nutrition, you're looking at patient and provider education, and then, of course, what we're going to be talking about, which is multimodal analgesia. Most importantly, when you look at the latest guidelines, the use of perioperative opiate-sparing multimodal analgesia regimen is considered Class 1 recommendation. As a matter of fact, when you look at the whole ERAC's perioperative components, multimodal analgesia and its components and its initiation and planning can be applied to the whole perioperative process. So this is something that we need to start looking at when these patients are coming to the office. This is not something that, as anesthesiologists, we're tasked with this, do something about this. And that's not where it starts. These patients need to be defined, who are high risk, who are low risk, and then a regimen needs to be implemented from the beginning. And that may mean that you get your anesthesiologist involved in that preoperative process. Recently, a joint conference between the Perioperative Quality Initiative and Enhanced Recovery After Cardiac Surgery Society convened to evaluate the literature and provide some sort of guidance on pain management in cardiac surgical patient population. They put forth this great summary, actually, of core principles that support opiate stewardship and the use of this multimodal analgesia in cardiac surgery, including the application of non-opiate medications and techniques, the utilization of opiates in a judicious manner. So again, they're not eliminating opiates. Patient-provider education, which is huge. Patient expectation is a huge component of what they're going to expect after surgery. And then, of course, a structured system-level opiate prescription management. Now, just to give you an idea of thoracic also, now there's a continued interest in the development and systemic implementation of these evidence-based perioperative care protocols. And when you look at patients who are undergoing thoracic surgery or any procedure via thoracotomy, there is no difference. ERAS pathways have been formulated and implemented at multiple institutions for these surgical patients also. Also, similarly, when you look at enhanced recovery, the multimodal analgesia and its components can be applied to the whole perioperative process. Many of these processes can be adopted for minimally invasive cardiac surgery, such as mid-cab, such as mini-cab, robotic cabbage, and since the access site, as I mentioned earlier, is often via a small thoracotomy. And the goals of nutrition, early extubation, and good pain management are no different for these patients also. One of the strongest level of recommendation in the recent guidelines for enhanced recovery in thoracic surgery is the use of regional anesthesia, which has been shown to be equivalent to epidurals, actually, and more importantly, reduce opiate use. Furthermore, when you look at specific ERAS pathways for thoracic surgery that have been published, they all demonstrate not only reduction in opiate use, but there's also a minimization of fluid overload. There's a reduction in pulmonary and cardiac complications, and there's a reduced length of stay and just overall decreased hospital costs because of this. This practice advisory, which was developed by the Society of Cardiovascular Anesthesiologists Quality, Safety, and Leadership Committee, their opiate working group also recommended paravertebral blocks and fascial plane blocks for acute pain management in patients undergoing thoracic surgery with a very high level of confidence and evidence, I should say. As a matter of fact, the Prospect Guidelines that was published in 2022 for pain management, specifically in VATS, but also for thoracotomy, recommended that in minimally invasive VATS, they recommended regional technique as first line for pain management, even against the use of routine epidurals. So now, ERAC, as I said multiple times already, ERAC's implementation includes this multimodal analgesia regimen, and it can have a great impact on reducing opiate use, and it works. It works. Here's a study looking at outcomes post-ERAC's implementation. It showed that the total opiate dose administered both in the operating room as well as post-operatively were significantly reduced. More importantly, the multimodal analgesia regimen does not only includes opiates, but non-opiates and regional techniques such as transverse thoracic plane blocks and serratus anterior plane blocks. Again, another recent study looking at pre- and post-ERAC's implementation within a multimodal opiate-sparing analgesia. This was in a small community hospital even. This wasn't even a large academic center. And what it showed is that the ERAC's patients significantly had significant reduction in opiate use. They had also had, of course, because of that, they had less nausea, they had less dizziness, lightheadedness, and of course, just overall patient satisfaction was higher because of this compared to their pre-ERAS components. Also, postoperative mobility was better, and postoperative length of stay was lower, which would be expected in patients who have a reduction in opiate use. And again, when you look at ERAS implementation in VATS and more importantly thoracotomy, it is also shown to be just successful. This study looked at over 1,000 patients, showed that when they implemented an ERAS protocol in patients undergoing a thoracotomy, patient outcome was improved, there was a decrease in opiate use, and of course lower hospital costs. So what is multimodal analgesia? Now, when I give this talk at an anesthesia conference, often everybody knows I'm not a pain management doc. I'm a cardiothoracic anesthesiologist. So there's more people in the audience who know about multimodal analgesia than I do. But this is a multidisciplinary audience, and so I'm going to go just a second into this. So the whole concept of multimodal analgesia is the use of more than one pain control modality to really achieve effective analgesia. This doesn't just mean pharmacology. It also means non-pharmacological techniques. This includes a very broad group of analgesics, so when you're looking at pharmacology, most of which work at different sites along the peripheral and the central nervous system. Now, by targeting, the whole point is by targeting different receptors and pathways, we can enhance pain control by producing essentially a synergistic effect. And then, more importantly, reduce the side effects of just one agent. And this, of course, decreases their dependence on opiates and, of course, manages pain more effectively. So when you look at multimodal analgesia, but just overall multimodal pain management, it consists of two major components, as I said already, pharmacological and non-pharmacological. And as anesthesiologists, depending on your subspecialty, there's an expertise in every one of these. Now, the treatment of chronic pain in cardiothoracic patients often requires the utilization of multiple treatment modalities, regardless of the etiology. Commonly prescribed medications include nonsteroidals, or NSAIDs, opiates, tricyclic antidepressants, serotonin and norepinephrine reuptake inhibitors, anticonvulsants, cannabinoids, muscle relaxants, benzodiazepines, and then, of course, topical agents have shown to be promising also, such as those that contain lidocaine, topical NSAIDs, and then, of course, capsaicin. Now, I'm not going to go through each one of these, but this is an extensive chart with multiple non-opiate agents that have shown to be used in multimodal regimens. The important, other than the information of the drug itself and the dosage, what's most important on this chart is that each of these agents have an important set of considerations, especially when you're utilizing it in patients with multiple cardiac and pulmonary comorbidities. Also, each one of these agents has a varying degree of evidence, and when applied to a multimodal regimen overall, and that's to be, as I said already, a whole different lecture in itself. But here's a great graph, actually. It looks at many of these analgesic agents in terms of where they lie, not only in terms of efficacy, but also their safety. And just as an example, this is a copy of our institutional multimodal pain management protocol. One thing to note here again is that this is a combination of both pharmacological and non-pharmacological therapies. Now, the use of pharmacological agents cannot be effective alone in cardiothoracic patients. Non-pharmacological modalities are an important part of a multimodal pain regimen, and often underutilized. Again, as I said, something unique that an anesthesiologist and getting an anesthesiologist involved in the whole perioperative process can bring to the table. Also, as we previously reviewed, regional techniques have not only been recommended in cardiothoracic guidelines and practice advisories, but it's a standard component now of many implemented ERACS protocols at many institutions. This is just one institutional protocol. And if you look at overall what many large institutions are using, they all look very similar and they all have some component of a regional anesthetic technique. So in conclusion, opiate dependence is still a problem in cardiothoracic patients. And the ERACS models are gaining a lot more popularity. When I first started giving these talks, most people in the audience did not have some sort of enhanced recovery care model. Now most people have something that looks like that. So not only are they gaining more popularity, but they may actually really be a solution to reducing chronic opiate use in patients and overall effective pain management in cardiothoracic patients. Thank you.
Hello, my name is Ali Shariat. As Dr. Bott said, I'm a regional anesthesiologist. So I came to the cardiac room and cardiac procedures as part of this association that we formed around 7 or 8 years ago. I have no disclosures, first of all. I will start by talking a little bit about neuraxial and paravertebral blocks and sort of their historical role. And then I'm going to get to the heart of the present talk, which are the fascial plane blocks, relatively new, and how they can be applied to cardiac surgery. And finally, I want to spend a little bit of time on issues regarding mechanism of action and sensory distribution, particularly with regard to the erector spinae plane block, because this will have consequences in regards to the application of this block and other fascial plane blocks to cardiac procedures. So 7 or 8 years ago, when our team, among many others around the world, first began to think about how to apply these novel fascial plane blocks to cardiac procedures and surgery, this whole topic was regarded as something kind of novel, a little bit exotic. People were coming to the room and watching what we were doing. But in fact, regional anesthesia has a very long history in cardiac procedures, particularly in the form of neuraxial anesthesia and epidurals. And there are many studies that have shown the utility of thoracic epidural analgesia as a post-operative method of pain control, including this one by Lehman colleagues, in which patients who were going for coronary artery bypass graft were randomized to receive either a thoracic epidural or no epidural, and those who received the epidural were awake sooner, resumed spontaneous ventilations earlier, and were able to be extubated earlier than those that did not. Moreover, there are several advantages of neuraxial analgesia that are very well known and important in this context. First of all, the effective pain control is not merely a matter of patient comfort, but has certain well-known systemic effects, such as the suppression of the hormonal and metabolic response to surgical stress. Also, the sympathetic blockade that is imparted by the epidural increases subendocardial blood flow, improves myocardial oxygen supply, and improves left ventricular function under stress. So, why is this technique then not more widespread? And of course, the answer to this is that the theoretical risk of a spinal hematoma has hampered the accumulation of knowledge and experience with this particular application of the epidural. Now, I have to stress here that there is not even a single case report that convincingly links an epidural in the context of cardiac surgery to a spinal hematoma. So, what is the actual risk that we are dealing with here? And Ho and colleagues figured this out to be between 1 in 150,000 and 1 in 1,500. That is the incidence of a spinal hematoma in the context of cardiac surgery when an epidural is performed. How did they figure this out? Well, the 1 in 150,000 is the risk of a spinal hematoma for a non-anticoagulated patient. So they figured that for a patient going for cardiac surgery, the risk is at least that high. And the 1 in 1,500 was calculated using an algorithm for an event that has not taken place. The truth of the matter is that these numbers are probably rather conservative in that the actual risk is considerably lower than this. However, for most practitioners, the risk of even a single such devastating complication in the context of a routine cardiac surgery is simply too high a risk to take. And also, I have to add that that very critical time when the signs and symptoms of a spinal hematoma need to be picked up in a very timely manner, that is that very time period that these patients are intubated and sedated in the ICU, making this risk completely unacceptable. So we move on to the paravertebral block. This is a block that has a far better safety profile in that there is not even a single case report of a spinal hematoma being attributed to a paravertebral block in any context. So the paravertebral block is performed in the paravertebral space, which is just adjacent to the vertebral body, where the spinal roots are exiting the intervertebral foramen. It is bounded anteriorly by the parietal pleura. Posteriorly, it's bounded by the costotransverse ligament, which the needle has to traverse in order to perform a successful block. And the paravertebral space blends laterally with the intercostal space. When you perform a paravertebral block, what happens is that you get an ipsilateral somatic and sympathetic blockade along multiple contiguous dermatomes, both cranially and caudally around the site of injection. So, what are some of the drawbacks of a paravertebral block, especially as we'll come to compared to the more novel fascial plane blocks that we're going to discuss? Well, first and foremost, it is a unilateral blockade. It's like a unilateral epidural. This cuts both ways. It can be an advantage. For example, you get less hemodynamic trespass than with a thoracic epidural because you only have half the sympathectomy that you would get with an epidural. Number two, but also this unilateral nature of the paravertebral block limits their applications, particularly in certain contexts in cardiac surgery, which I'll come to in a few slides. It is also an advanced procedure. Not all anesthesiologists are comfortable performing this. It does require positioning of the patient prior to the procedure, which can be uncomfortable. And most importantly, as far as we're concerned, it is a deep block, which means that we have similar concerns as with an epidural, because ASRA guidelines do state that for patients undergoing a deep plexus block, recommendations regarding neuraxial anesthesia for anticoagulated patients should be similarly applied, despite a lack of evidence linking the paravertebral block to a spinal hematoma. So at the very least, we have medico-legal concerns here with performing this block. Nevertheless, the paravertebral block has been studied quite widely in the context of cardiac surgery, particularly minimally invasive cardiac surgery through an anterior thoracotomy. This is one study by Dole and colleagues in which patients going for minimally invasive cardiac surgery were randomized to receive either a unilateral paravertebral catheter or a thoracic epidural catheter. And those who received the paravertebral catheter was found to be equivalent to the gold standard epidural. And so in this study, the advantage went to the paravertebral catheter, of course, because of the better safety profile, the better side effect profile of the paravertebral catheter. So the question is, if one can use a unilateral paravertebral catheter for minimally invasive cardiac surgery, can you use bilateral paravertebral catheters for patients who are going for a traditional sternotomy procedure? And this is exactly the question that was studied by Ho and colleagues. This is Manoj Karmakar's team in Hong Kong. And they placed bilateral paravertebral catheters in these patients who were going for sternotomy procedures. Very interestingly, despite the fact that the dose of ropivacaine was well below the calculated toxic dose, all patients who received the bilateral paravertebral catheters has post-operative mental status changes that were consistent with local anesthetic systemic toxicity. And this study was terminated after only 7 patients, right? So this is cautionary, and it underlines the limitations of the paravertebral technique, especially when applied to cardiac surgery. And that brings us to the fascial plane blocks. And these are blocks that are performed between the fascial planes that separate the muscles. So they're kind of different from our traditional conduction nerve blocks, where we are actually visualizing on ultrasound the target nerves, for example, in a brachial plexus block, and we're visualizing the local anesthetic surrounding the nerve. In this case, we are depositing local anesthetic in the fascial plane where the nerves are present, without really being able to visualize the actual nerves. So this means that there is a certain variability in the sensory effect of these blocks, right? There is a certain failure rate even in blocks that one performs absolutely perfectly. There will be a certain failure rate, and for this reason, these blocks are not used for the primary anesthetic. These blocks are used as part of a multimodal analgesic regimen. But they do have a number of advantages as well. There are relatively easy blocks that are in superficial locations, and there is a low risk of injury and complications. The first blocks that I'm going to talk about are the superficial and deep parasternal intercostal plane blocks. These blocks target the anterior cutaneous branches of the intercostal nerves between T2 and T6. This is the innervation of the sternum. And the blocks are performed just adjacent to the lateral sternal border. With the superficial parasternal block, local anesthetic is deposited between the pectoralis major and internal intercostal muscle, whereas with the deep parasternal block, the local anesthetic is deposited between the internal intercostal muscle and the transversus thoracis muscle. And that second arrow is the location of the deep block. So the image on the right, you could see just superficial to the pleura, there is a hypoechoic band that is the transversus thoracis muscle. And so, as you could see, due to the greater proximity of the deep parasternal block to the pleura at least theoretically, there is a higher chance of pneumothorax when performing this block. Also, it must be noted that the internal mammary artery is located in the deep parasternal plane, and therefore, if this version of the block is the one that one chooses, it's mandatory to perform a Doppler ultrasound because the echogenicity of the internal mammary artery is very, very similar to the transversus thoracis muscle. And finally, if a patient has had a prior internal mammary artery harvest, that deep parasternal plane is obliterated, and this has obvious consequences with regard to spread of local anesthetic in this plane. And this was demonstrated very nicely by this cadaveric study by Fujii. And you could see on the right side, where no internal mammary artery harvest has taken place, when there is injection of dye, there is very nice even spread between T2 through T5. This is exactly what one might expect when performing a parasternal block. However, on the left side, where there was a prior internal mammary artery harvest, we could see that the dye is restricted to the level of injection. So for a patient coming for a re-op, the deep version of this block would not be the correct version to perform. For all these reasons, many teams, including our own, opts to do the superficial parasternal intercostal block preferentially. Nevertheless, the deep parasternal block, which was previously known primarily as a transversus thoracis plane block or TTP block, has been studied in cardiac surgery. This is one study by Fujii and colleagues in which patients were randomized to receive either bilateral deep parasternal blocks or no block. And we could see that for the first 12 hours post-extubation, the patients who received the block had significantly lower pain scores. These pain scores evened out at 24 hours post-operatively. The superficial parasternal intercostal block has also been shown to be useful as a rescue analgesic in patients who had undergone a sternotomy procedure and who had intractable pain. This is a case report. We could see in this case, pectointercostal fascial plane block is the name that the superficial parasternal block was previously known by. And this patient had resolution of his pain with the performance of bilateral superficial parasternal blocks with a significant decrease in opioid consumption. I'm next going to talk about the PEX 1 and 2 blocks and the serratus anterior plane block. The PEX 1 block is performed between the pectoralis major and pectoralis minor muscle. It's what is shown on the left. The target nerves are the lateral and medial pectoral nerves. The PEX 2 block consists of the PEX 1 block as well as a second injection, which is performed between the pectoralis minor and serratus anterior muscle. And this then blocks the lateral cutaneous branches of the intercostal nerves, as well as the long thoracic nerve, the thoracodorsal nerve, and an opening of the axillary corridor. Finally, the serratus anterior plane block is performed at the mid-axillary line between the latissimus dorsi and the serratus anterior, and the target nerves are the lateral cutaneous branches of the intercostal nerves between T2 through T7. These blocks have been applied to cardiac surgery. This is one study of pediatric patients undergoing minimally invasive surgery, and the patients were randomized to receive either a serratus anterior block, PEX 2 block, or multiple contiguous intercostal blocks. And we could see that post-extubation, in the first 4 hours, all the patients had pretty similar pain scores. However, after the 4th hour post-extubation, the fascial plane groups do better in terms of pain scores than the intercostal blocks. This is something that we would expect. The intercostal blocks have a very high systemic absorption of local anesthetic, which limits their duration of action. With the fascial plane blocks, we're performing these blocks in relatively avascular space, which increases their duration of action. This is a retrospective study of patients who underwent minimally invasive cardiac surgery, and they had received either a serratus anterior plane block or wound infiltration. And those who received the serratus anterior plane blocks had significantly lower pain scores in the first 48 hours postoperatively. And finally, coming to the erector spinae plane block, or ESP block, this is a technique that has garnered a lot of enthusiasm in the last several years, but also has a certain amount of controversy related to its mechanism of action and sensory distribution. Local anesthetic is deposited between the transverse process and the overlying erector spinae muscles, resulting in a craniocaudal spread of the local anesthetic, which in the first case reports by Ferrero and colleagues resulted in a very large sensory distribution of almost the entirety of the hemithorax. These were chronic pain patients who had chronic neuropathic pain of the thorax, and the block was surreptitiously discovered because the trigger point for the pain was exactly at the erector spinae plane, and they injected local anesthetic, and they found this wide distribution of numbness in these patients. However, I'd like to point out that even in these initial reports, the sensory distribution anteriorly ended at the midclavicular line, and we could see very clearly sternal sparing. So as Dr. Ba had alluded to earlier, pain after cardiac surgery is multifactorial. But at the same time, we should have a good idea of which aspect of the pain we're addressing with the block. So the initial mechanism of action that was suggested for this block was that the local anesthetic not only went in a craniocaudal direction, but also advanced anteriorly towards the paravertebral space. And the idea here was that the local anesthetic gained access to the paravertebral space through fenestrations in the costotransverse ligament, hence the paravertebral by proxy theory for the mechanism of the ESP block. Now, the problem is further cadaveric studies, particularly this one by Ivanusic and colleagues, failed to corroborate this mechanism of action. In this case, they found that no dye could be found in the paravertebral space after the dye was injected in the erector spinae plane. On the contrary, the dye spread laterally to the lateral cutaneous branches of the intercostal nerves. That would certainly explain the sternal sparing that we observed initially in Ferrero's case reports. The situation became even more complicated because of the fact that further volunteer studies in healthy volunteers showed a sensory distribution that was far more limited than that which was shown by that initial case report of Ferrero. Here, in this volunteer study by Zhang, we could see that in all cases, the sensory distribution is limited to the posterior thorax, right? So this is where the controversy surrounding this block stems. There are people who have spoken of this block as a golden bullet for postoperative analgesia, and the detractors who feel that the true mechanism of action may be actually systemic absorption of the local anesthetic and a central effect, right? So it's very polarized. Nevertheless, the erectrospiny block has been studied fairly widely in the context of cardiac surgery. And there is burgeoning evidence that there is some usefulness in the application of this block. So this is one study by Krishna and colleagues in which patients going for coronary artery bypass surgery through a midline sternotomy were randomized to receive either bilateral one-shot ESP blocks or no blocks. And the patients who received the blocks had a shorter time to extubation, had a lower need for postoperative opioid use therapy, and they spent less time in the ICU than those who did not. This is a study by Philippe Macquart's group in which they used bilateral ESP catheters in patients going for cardiac surgery and compared them to historic controls. And they found that the patients who received the ESP catheters had lower postoperative opioid consumption in the first 24 hours postoperatively. So where does the truth lie here, right? So we've had different perspectives, and I think when we apply these fascial plane blocks, we have to temper our expectations because as I stated earlier, the mechanism of action is different from the traditional conduction nerve blocks that we perform in regional anesthesia. And so there is that variability in sensory distribution, and there is inherently a certain failure rate, right? And hence, these blocks are not, as I said, used as a sole anesthetic, right? They must be incorporated in a multimodal analgesic regimen. Also, dense block is rarely seen. As such, a block like the ESP behaves nothing like the paravertebral block, where we can actually institute surgical anesthesia with the paravertebral block. That is not possible for the fascial plane blocks. And finally, it has to be noted that we have seen in these studies a clinical effect that is in excess of what we are observing in terms of dermatomal distribution. And so the dermatomal distribution may not be the best evidence of the efficacy of these blocks. There are other aspects of pain that cannot be analyzed with such tests, such as the osteotomes, such as myotomes, and such as the possible role of the fascial planes themselves, which are very richly innervated in the pathogenesis of postoperative pain. Also, the expectations of patients must be tempered, as these blocks are not the golden bullet that were advertised by some. They do not totally eliminate the need for postoperative opioids. In fact, there are now studies that suggest that patients who do not get appropriate amounts of opioids postoperatively actually develop out-of-control pain in the immediate postoperative period, have a higher risk for developing chronic pain, and have a higher risk for having a need for long-term postoperative opioids, meaning more than 6 months out from surgery. This is exactly what we're trying to prevent. And so this opioid-free theory of postoperative pain regimen is losing favor little by little. So in the future, we need more well-conducted randomized controlled trials to further establish the efficacy of these blocks for cardiac surgery. We also need to improve the way that we are administering these blocks and tweak the technique in terms of the type of local anesthetic that we're giving, the concentration of local anesthetic, whether or not these blocks can be amenable to using a continuous catheter. These are all things that have to be better studied and better delineated. And finally, we need to put these blocks in the context of a well-thought-out multimodal pain program where the opioids are not entirely eliminated, but are optimized. So I went through, in conclusion, a little bit about neuraxial and periorbital blocks. These blocks, I believe, because of their bad safety profile in the context of cardiac surgery, these will not be coming back in this context. And we talked about the peripheral nerve blocks. These are adjunct pain techniques, and they are part of an opioid-sparing approach. Thank you so much.
Yeah, I was just going to come up and say, does anyone have any questions? Go ahead.
Hi, good morning. Rakesh Arora, University Hospitals in Cleveland. Thank you. Two excellent, very detailed talks. I have three questions, one for Dr. Bott, one for Dr. Shariat, and then one for both of you. For the approach to multimodal analgesia, it really requires a team approach that goes through all three phases of the surgical journey. Tell me a little bit about what you do in the preoperative phase to involve your preoperative team to program patients to know what post-op discomfort may look like, and how you engage your post-operative team to recognize that pain is really essentially a medical emergency that needs to be treated rather than just following the Q4 to 6 type of regimen. Tell me a little bit about how you've organized your team around that.
So, this is working, right? So first of all, one of the things, and I say this all the time, that I am not a pain expert, but my forte is cardiothoracic anesthesiology, critical care, all of that. And so one of the first things I did was actually create a team. Before I even started any of this, I didn't initiate anything. I got a regionalist involved. I got an ICU doc involved. I got my nursing administration involved. I got all of the pieces that I felt were going to add to the success of a program like this. Then I started small. So we were at a center where we did robotic cabbages. So I started with that cohort of patients. Patients were meant for fast tracking. They're meant for that sort of rapid turnover, decreasing length of stay, early extubation, all those things that were already components of a slowly developing enhanced recovery sort of care pathway. So to answer your question, I first started off with a team. And so each of these teams, with the teams came their expertise. They were already looking at their expertise was looking at preoperative things. My expertise was looking at intraoperative things. And the ICU docs and the nursing administration, their expertise was looking at postoperative planning. Then, as we started to develop small protocols, one of the first things I said was I reached out to colleagues and I said, hey guys, what are you doing? Because I know you have a well-developed, robust program. And I started to take components that fit into my system based on the resources I had. And that eventually developed into a truly perioperative process. Does that answer your question?
It does, and part of that magic sauce is also the metrics that each of those people would look at as part of the team. So how have you continued to engage them saying, well, we know we're making a difference based on what elements for each of those team members?
Well, so initially it was anecdotal. Initially, it was anecdotal to even see if this is working or not. And as you can see, when you talk about just pain management, there's so many different flavors of cardiac pain. So it was a matter of what is working, what is not working. That evolved into sort of retrospective analyses, which are all published now. And then that has evolved into prospective studies that we're currently doing right now, out of which two of them, one has been published already, one is in the process of being published, and 1, 2, 3 of them are underway right now of collecting data, actually randomized control studies. So to look at metrics, again, and this is going to speak a little bit to my specialty is more intraoperative pain management, but the initial one that we looked at was the whole process, preoperative, pre-medications. Our first study that came out was just looking at different blocks in different patients and to see what opiate consumption was and how much pain the patients had post-operatively. Then we took on pregabalin because there's a lot of controversy around that, the gabapentinoids. And so that's also a published study now, which showed that there was a slight decrease in cardiac patients, and more importantly, we didn't see any major side effects. And that evolved into a lot of this collaboration that you see here of actual, not only retrospective large studies, but now prospective studies, which are underway publication.
Great. Second question is for half of our anesthesiologists don't believe in blocks, so they just don't do it. And so we have this group of patients who have really good pain on the first post-operative morning and trying to rescue them at that point in time with the acute pain service. And I find it remarkable, one, that we have a group of anesthesiologists who don't believe in it, but two, the patient's resistance to having blocks done on post-op day 1, even though they just had, sternotomy and cardiac surgery. And it may be the way that our APS team is approaching them. Tell me a little bit how, if you have to rescue a patient in the post-op day 1 with ongoing pain that's not managed in our traditional way, how you approach that patient. Specifically neuraxial blocks.
Neuraxial.
Well, with regional anesthesia.
Regional anesthesia. Yeah. Okay. So in these patients, we because they're in a monitored setting already, it really makes things a lot easier for us. I mean, have we been giving sedation to these?
No.
No. Okay. So really, we have to talk to them. We have to convince them of that it's just a small needle, that it's no more traumatic than an IV being administered.
Yeah, the challenge is, like the data you showed, it's quite a wide range of published incidents of hematomas and so forth. And our APS team is very conservative with this. And so they'll giving this whole range, saying it's 1 in 2,500 or 3,600 to 150,000. The patient only hears the highest risk. So again, it comes down to how it's crafted and how you approach that patient a little bit.
I'm sorry, hematoma.
With the slide you showed about the range of incidents of epidural hematomas.
Of epidural hematomas,
yeah.
but nobody will do the epidural, I think, post-operatively.
No, but I think they use the same information for talking about hematomas.
For paravertebrals.
For ESPs or other sort of...
So there's no evidence that a fascial plane block causes a hematoma, particularly like a spinal hematoma. There's absolutely no evidence, and there's no fear of it. You could perform these blocks in patients who are anticoagulated. It's not a concern in that.
As a matter of fact, the recommendations are different. So if you look at the American Society of Regional Anesthesia, the ASRA recommendations for performing a lot of the fascial plane blocks, or peripheral nerve blocks, are very different to neuraxial, such as spinals and epidurals, and then of course some of the deeper plane blocks, the deeper plexus blocks. The recommendations that they say in anticoagulated patients are actually significantly different.
Yeah, our APS service won't even do it if we do sub-Q heparin in the morning. So we have a very conservative group in this. So
yeah, those should be no problem.
Oh, I agree with
peripheral
you.
nerve blocks.
I'm not the.
Particularly under ultrasound guidance. This is a relatively avascular space. There is absolutely no concern in that regard.
And I'm gonna answer the question about the ICU because I'm the one that manages a lot of the rescue blocks in the ICU. So I've had patients who come to me begging for a rescue block even though they didn't agree to be in the study to begin with. So I feel like at that junction when you're in pain, you're like, I'll take whatever you give me, lady. Right? Like that's actually the response I get. So I usually don't have a hard time convincing patients who have true postoperative pain of, hey, listen, I'm going to try this. It's not going to be 100%, but it's definitely going to be a great adjunct. So that's one. And two, for the patients that start off with the regional anesthetic to begin with, I tell them that there's a confined time frame within which this works. And if you need it again, we will come back again and do it for you. So they already have this predisposed understanding that, hey, listen, if something isn't hurting and is hurting more now, then I can always reach out to the same team that did all of my sort of preoperative / intraoperative care. So they already have that, I guess, sort of thought in their mind.
Right, last question I have for you, because I'm monopolizing all the time, but I'll let the gentleman behind me go. Any thoughts about effective acute perioperative pain control and its impact on long-term pain? My sense is if you get good pain control up front, patients don't have as much long-term pain. Any thoughts around that? Is that any data to support that theory?
I'm sorry, once again, patients about acute
so those
versus...
who have effective early postoperative
Yeah.
pain control are less likely to have chronic pain syndromes, just anecdotally. Is that sort of
Right.
in your experience? Or
Absolutely, 100%. There's more than enough scientific data to show that there is an initial inflammatory response with any surgical procedure. Forget cardiac. So now the difference in cardiac, which is significant, is that the pain is multifactorial. It's not as simple as you make an incision here, this hurts. So that's where the hurdles, I think, in pain management in cardiothoracic surgery come in, as opposed to any of the other surgical cohorts. So, but the science behind that is that if you look at inflammatory markers, there's plenty of data to show that the initial surgical response is within 5 minutes. And the inflammatory response is pretty significant, just as it is in cardiac surgery. How much do these multimodal regimens attenuate that inflammatory response, therefore not leading to long-term pain syndromes in cardiac patients? There is not a lot of data on that. And that's interesting because that's something that we're looking in next.
A study we need to do.
Yeah, we're actually in the process of putting together that study right now as we speak.
Hi, thanks for the really comprehensive. I'm a surgeon, so this is well beyond my realms of understanding. But what I do understand is that we as surgeons are trying to become more and more minimally invasive. And we cannot talk about minimally invasive if the pain control is not, and the management is not up to date. From what I've seen today, it is a hugely complex issue, and nobody has the right answers yet. So simple solutions are generally what work. We have found multi-vessel mid-cab as what we're striving to achieve with extubation on the table.
So
Do you think
you're extubating the patients on the table as part of, it's 100% of patients.
That's what we're trying to achieve. So that is our goal. We haven't achieved that yet for two reasons. One, we cannot keep the patients warm properly, because if you extubate them on the table and they're cold, that's not a good option. And second of all, if their pain isn't under control, that is also not a good option. So have you been trying to strive for that? Is that what your goal is as well? Because as surgeons, that's where we're going. We've found in Dortmund, Professor Albert puts an epidural catheter in the wound with bupivacaine, an infusion.
So now you're referring to probably the on-Q catheter. It's an on-Q system. I mean, I don't care what they call it, but the point is that there's a catheter actually within the intercostal space. It goes ahead and sort of covers the intercostal nerves. If your surgeon is good at it, because I've seen sort of a 50-50 there with surgeons who are very, very well versed with it, and it's very effective versus this thing is just sort of there, and half the times I'm pulling it out and I'm doing actually something else for the patients. So that's one aspect of the catheter itself. As far as intraoperative extubation is concerned, so the data shows very little response to ultra fast tracking, which is the extubation on the table, right? So there's the school of thought is fast tracking and ultra fast tracking. Ultra fast tracking comes down to extubation on the table. Fast tracking comes down to whatever metrics you follow, state-wise, et cetera. Most of the time, the goal is within 6 hours. At our institution, we hope for 4 to 6 hours. We shoot for that. And if I say, hey, the patient's moving in the elevator, that's great. So it's very close to that 4-hour mark is what we always try to achieve, and therefore we cater a lot of the preoperative and the intraoperative medications to that. But to speak to that, that is not what we're ultra fast tracking, which is extubation on the table, is not something that we are currently trying to attain because there's no data to support that. There's no data to support any advantage over that. As a matter of fact, reintubation, improper pain control, waste of OR time, waste of OR resources, these are the things that some of the papers actually talk about. And so now, don't get me wrong, not every paper is correct. You sort of put all that together and take it with a grain of salt. But I have not seen, in my experience, attempting to extubate patients on the table, a true advantage. Catering these patients to that very early extubation, that we've been successful at. Especially if they're straightforward, no coagulopathy. Then you can take them upstairs and you can keep them warm, you can correct the coagulopathy, you can manage the pain better, you can implement all these systems, and then really plan for that first 4-hour extubation.
And although it's outside of the realms of this meeting, but how do you keep them warm?
Well, so, I mean, intraoperatively, first of all, there's fluid warmers that we use consistently, now based on how much fluid I can give the patient. You know, immediately after we come off bypass, we turn on bear huggers. We actually increase the temperature within the room itself significantly, and it's, as a surgeon, you can appreciate when you're sweating a little bit, and the anesthesiologist is calling for the temperature to be higher. So that's what we usually do to keep these patients warm. We do manage coagulopathy right away. We have viscoelastic testing. We have the latest ROTEM machine, point of care, iStats, all of that. So we have that readily available where most of the patients coming off bypass get that anyway. And so the coagulopathy is controlled early to begin with, for example. And so as far as warm, fluids, body temperature, bear hugger, so looking at forced air systems and stuff like that. These are effective. We found them effective. We were doing the gel-based. Now, there's multiple different vendors that do this. We were doing that, and it was actually quite effective. However, we were seeing sort of random skin breakdown at times, and we were a little concerned about that. So we did eliminate that, and we switched to the bear hugger system again. And we've been relatively effective as long as we're thinking about it. So even at the end, if we're waiting for the bed, the temperature of the room is already warm. There's a second bear hugger on top of the patient with blankets when we're monitoring the temperature. And the minute we get upstairs, our ICU also implements a bear hugger on the patient, and therefore we're better capable of maintaining the temperature upstairs.
Great. Thank you very much. Great session.
Can I push back just on the ultra-fast track for a minute? I don't agree with you. I think there's a real benefit to those centers who do it well. Having worked in a center where 60% of our patients are extubated in the operating theater, yeah, it can slow down your turnover a little bit, but turnover is usually ridiculously long anyways, and I don't know makes that much of a difference. But I will say, if your team does this well, then it becomes more of an issue. Why is this patient still intubated when they come out to the ICU? Because there's something different about that patient. So the tune of the team is very different if you have a center that does this routinely and does it well.
Right.
And
so they're right. You have to set. It's not just a matter of the operating room, but it's also post-op. The logistics of the team in the ICU has to be ready for that type of patient. So we're a mitral valve center we're at the main center. We're a mitral valve center, and I did that for almost 10 years. And these patients were 40-year-old Barlow's valve. Obviously, if I'm waiting for a bed for more than 2 hours, I'm extubating that patient. But then again, I have 2 hours. There's nothing following in the room. I have no pressures to turn over the room and get the next patient in. I'm waiting anyway for that. So the average 45-year-old with a Barlow's valve who has a preserved ejection fraction, and I'm basically the intensivist in the room. So it's completely acceptable. Right. But the logistics around the whole system have to be set up much more. It's not just the operating room.
I think our colleagues at the thoracic side had figured this out a long time ago and avoid the ICU altogether. I think this mentality that we can't because cardiac's different, I think it's I don't believe in it personally. I've seen it done well, and our anesthesiologist gave the same anesthetic if they were doing a lap chole. That was just their mentality.
Right.
And so they were awake, extubated, and talking on the way to the ICU. So again, I think it's a mindset. The same as that you have to have a mindset of multimodal analgesia. It's the way we approach the whole anesthetic process. In that this is not different than a thoracotomy or a VATS or elsewhere for those procedures being done now, particularly mini-invasive. And I think it's just a mindset we have to get ourselves out of.
Yeah, no, I don't disagree with you. It's not only the mindset, but the whole system has to be in place. Like, it's a culture. It's a culture change, right?
We've done it for thoracic.
And a straightforward cardiac surgical patient can easily be extubated on the table. Again, the data just doesn't speak to the advantage of that, though, yet. I think that majority of the studies that come out they're not necessarily robust prospective data. They're usually just looking at some sort of retrospective analysis, et cetera,
yeah,
right?
that's right.
Let's see, we kind of did this, we didn't do this, and we're looking at a comparison. And also, many of those places probably didn't have a solid sort of infrastructure that this is what we do. Also, you have to identify these patients to begin with, right? Not everybody's extubatable on the table, and I think that's where people fail.
Yeah, all that's true. You need an approach for those patients. You need good patient selection, meticulous surgical procedure, and a proper sort of plan on how you're going to extubate that patient in the OR in a safe way so they have good pain control. All those things are correct, and you need a team who can reintubate, which thankfully, most cases is pretty low, to be honest with you. The center, I know the group out of Virginia had a different rate of higher rates of intubation in their 17 center system, but it can be done. And I think
It can be done, but it takes a little bit of steps, yeah.
Thank you. This concludes our perioperative program. It will resume tomorrow, 8 a.m. in this room.